you on the mute now. I'll just start off the meeting. I hope everybody's on the mute. A very good evening to one and all of you. You all have absolutely no idea how excited and elated I am to have the absolute top cream of the country on the panel today. And of course, our very special international hero is there with us, Dr. Grover, and I'm sure the next 2.5 hours is going to be the most exhilarating and exciting event which has happened since a long, long time. So we are not going to waste time. The topics are very interesting, have been very well thought of and laid out. And with you, expert, to piecemeal discuss it all, I'm sure all our audience are going to have a great time. I'm truly thankful to Dr. Harsh Kumar, who's the Director of Glaucoma Services from the Center for Sight Group of Hospitals based at New Delhi, and an amazing glaucomatologist of the country, for being with us today. I'm truly grateful to Dr. Surinder Singh Pandav, who heads the PGI Center based at Chandigarh, and who has been the president of GSI, and another very eminent glaucomatologist of our country, to be our esteemed panel. We are truly lucky to have with us Dr. Shishmita Kaushik. I have some of the best memories of her leading us through those glaucoma webinars during my ARC term. And she is a senior professor of ophthalmology from PGI Chandigarh. Again, a very eminent glaucomatologist, and I'm sure we're going to learn a lot from her. Joining us soon is going to be Dr. Lingam Vijaya, who is again a top-notch glaucomatologist of the country, senior consultant at the Medical Research Foundation, Shankar Nethralaya, Chennai. And with us, joining us soon, is going to be Dr. Krishna Das, who's again the Director of the Human Resources Development, Arvind Eye Care Systems, a senior glaucoma surgeon from the Arvind Eye Care Systems based at Madurai. We have with us Dr. B. Shanta. I'm truly happy to have you with us. She's again a senior consultant glaucoma services from Shankar Nethralaya. Again, a very terrific glaucomatologist to have amidst us. Co-moderating with me is Dr. Murlidhar, a very dear friend, who's also a senior consultant in glaucoma services, pediatrics, and neuro-ophthalmologist, is an icon at our Eye Foundation group. And I'm sure with him, we are definitely going to keep you all on your toes, answering all the questions which you're going to ply you with. Now, before we go on to the speakers, we have divided it into different groups of different case scenarios. So I'm going to take up the first thing on, before we do that, I'm sorry. We'll go on with Dr. Grover's talk, sorry. And then we go on to different sessions, which I would elaborate on. So our keynote speaker is Dr. Davinder Grover, a senior glaucomatologist and an extremely eminent world-renowned glaucomatologist from the Glaucoma Associates of Texas. Again, he has been one of our very interesting faculty members in one or two of our ARC meetings during my term. And I know how he is going to captivate us in the next half an hour with a very challenging topic: managing refractory glaucoma, my step ladder approach. It's going the next 30 minutes. I'm sure there's going to be nothing left for us to learn. On to you, Dr. Grover.
Amazing. Well, thank you all so much. Dr. Chitra, thank you for inviting me. It's always a pleasure to talk to friends, and it's been a while since I've been to India. So I'm hoping one day soon I'll be able to come out there now that things are normalizing. But it's always a pleasure to have this ability to engage virtually from across the world. And yeah, I really appreciate this opportunity to speak also about this topic, because it's something I feel pretty strongly about. And usually when I'm giving talks, I'm talking about how to do this surgery or how to do this surgery. And what I liked about this topic was it's really going to just allow me to kind of pontificate and talk about my general philosophies on management of glaucoma and my stepwise approach. These are my disclosures. Some of them are pertinent, really, but this is more just my philosophical approach to patients that have glaucoma and how I manage them. And what I'm going to first start off by doing is just defining some terms. So, the first thing we need to do is we need to define what refractory glaucoma is. And then I want to introduce an idea that many of you have probably heard on what is interventional glaucoma. And then I'll talk about my general surgical algorithm and my not just stepwise approach, but what I like to think about is my cost-effective stepwise approach to glaucoma treatment. Oftentimes when we're talking about glaucoma, cost effectiveness is not really a main focus, which it needs to be, especially when it comes to MIGS. So, what is refractory glaucoma? So, back in the day, 30 years ago, 20 years ago, it was patients that have had multiple failed trabeculectomies, right? And that's refractory glaucoma. But I would say that refractory glaucoma has, it's still being defined, and it's all relative. So you can have medical refractory glaucoma, you can have surgical refractory glaucoma. But, is a patient on maximum medical therapy are they refractory? Do they have to have had multiple incisional glaucoma surgeries to be refractory? What if a patient's on, all their tolerated drops? What if you can control them on all, 5 agents and oral acetazolamide and they're controlled? But are they going to do that every day? Or, maybe they can't afford their medication, or maybe their medication caused their eyes to be beet red and they don't do their drops. Or they live, in a remote village and they can't get access to that. So I think all these scenarios actually can define what I consider refractory glaucoma. I don't think it's reasonable to expect our patients to be on multiple drops, 6, 7 drops, dorzolamide, timolol, brimonidine, latanoprost, pilocarpine, acetazolamide, all that every day, multiple times a day for the rest of their life. That's not reasonable. But I don't also think that we should have to wait until someone is having 3 or 4 failed incisional glaucoma surgeries to be considered refractory. So I think that definition is still being determined. But my definition is there's refractory medical and refractory surgical glaucoma. So what is interventional glaucoma? So now we have a lot more interventions than we did when I've been practicing now for 13 years. When I first started, we didn't have a lot of these surgeries. In my first year of practice is when we came up with some of these minimally invasive surgeries that have now changed everything. But when I was in training and a resident and a fellow, we didn't have a lot of these things. And so I think now that interventions are becoming safer and less invasive, it's changed our decision-making process. And it's changed our threshold, or it should change our threshold to intervene. Not, when trabeculectomy was the only option, it makes sense, right? To put patients on all the drops and oral medications, because the alternative with surgery, trabeculectomy, is not a fun option. And it has some inherent risks that could lead to further loss of vision. So it made sense to hold off on intervening. But now we have a lot of interventions that I think are much more favorable on the safety spectrum with decent efficacy. And this, we have, at least in the US, we have the sustained release medications. I know we have SLTs available, thankfully, everywhere. A lot of these MIGS, microshunts are available, and some of these glaucoma drainage implants are becoming a little bit less invasive. In the US, we have the 250 clear paths, the 185 Maltinos. I know in India with the Adi, you guys can easily just trim it and make it a smaller implant if you needed to. But we can push the limits as far as our ability to intervene in a somewhat safety way. And so, some people are saying, well, Dr. Grover, Devinder just likes to operate. He just likes to do lasers and do all these things. Why are you intervening early? Just put patients on drops, put them on brimonidine, dorzolamide, timolol, latanoprost, and just have them go home. Well, we're seeing more and more data that early intervention is better, and intervention and getting patients off drops are better. So just back in January, they published the 6-year outcomes on the LIGHT trial. And that's such an important article to read. It was in, I think it was in ophthalmology, glaucoma, if not ophthalmology. But it was a continuation of the LIGHT trial and the data that came out at the 3-year point, showing even more convincing evidence. and when they randomized patients to latanoprost versus SLT, that the SLT group still did better. They were less likely to need glaucoma surgery, less likely to need cataract surgery. And why is that? Right? Well, maybe patients aren't using their drops, right? Compliance and adherence is always an issue. But it really makes us wonder whether, are these drops as benign as we think? Do we really think patients putting drops in their eyes every day, multiple times a day, is healthy for the eye? Right? Is it healthy for the structure of the eye? Is it healthy for the outflow system, the collector channels, the episcleral vasculature? And we're seeing more and more data that maybe that's not the case. And this was really a powerful article that came out in 2022 out of Japan. And it's evaluating and proving something that I think we've seen a lot. And I actually saw it firsthand the very first time I came to India to do GAT. Because in the US, when I'm doing GAT on patients have been on drops multiple times a day for years and years and years on end. Whereas when I came to India the first time for GAT surgery, I was taking care of a lot of advanced patients. They gave me all the most advanced patients, but these eyes had not been on drops for a long time. They presented advanced, and they had maybe only been on timolol once a day for 3 months. Those eyes were pristine. Even though they had very advanced glaucoma, the tissue was healthy. The trabecular meshwork was compliant. The canal was intact. I do angle surgery on people in the US that have been on drops for 20 years, and their canal is sclerotic and it's tight, and I can't get in there because it's so scarred. And so what this group out of Japan did, Dr. Akuda and everybody, they looked at their patients that underwent a tenedo goniotomy, and 146 eyes, or 146 patients. And they defined success as having a range of pressures, having IOP greater than or equal to a 20% reduction, and no incisional glaucoma surgery. And then they looked at length of time that a patient has been on glaucoma drops. And 4.5, I think, was kind of the median number. So they said, okay, who's been on drops for longer than 4.5 years? Who's been on drops for less than 4.5 years? And what did they find? They found that at 4.5 years, if you've been on anti-glaucoma medications for less than 4.5 years, your chance of success at 1 year after a minimally invasive glaucoma surgery was in the 70s. But if you'd been on drops for a long period of time, over 4.5 years, your chance of success, all things being equal, is half. It's 50%. It's like flipping a coin, right? So why is that? Well, I kind of talked about it, but are we so naive to think that when we put patients on these drops, and this is what happens to their eyes sometimes, prostaglandin orbitopathy, irritation from dorzolamide timolol, the atrophy and the damage of this chronic exposure to drops, do we really think that's not harming the eye? That's not changing the health of the trabecular meshwork, of the collector channels, of the episcleral vasculature? 100% it is. Without question it is. And so drops are not as benign as we think. And we're doing this to patients. We're doing this, and we've been doing this to patients for the past, since the beginning of drops, especially since the 70s, but even before then. And it's miserable. And you see this prostaglandin orbitopathy, and it's just devastating. And it makes glaucoma surgery more difficult. But I also think there's now more and more data showing that it makes glaucoma surgery less likely to be successful. So I think interventional glaucoma is an important component to think. We need to shift our mindsets that early intervention is something we need to start considering. Our goal is to lower IOP. My goal, these are my goals when I treat glaucoma: lower IOP, decrease or eliminate my patients' dependence on drops. They don't use their drops, and when they do, they're miserable, and the drops can be harmful. I want to prevent progressive optic neuropathy. And mostly, with the safety of MIGS, I want to avoid any serious, devastating, sight-threatening surgical complications. And I think there are some less invasive surgeries that will allow us to do that. So, and this is kind of my general surgical approach to patients, right? So I'm either going to enhance their own outflow system or create a new drain. or you can and create a new drain or reduce inflow. I should actually have another arm in there on the top part with the intact collector system that has SLT, because I think SLT is now such an important component of my surgical management. And so let's talk. And this is really, I've never sat down and actually written down basically my order of approach to intervention, and so it was really interesting to sit down and think about what I do on a daily basis. And I think this kind of sums up my surgical approach to glaucoma. First, when a patient's diagnosed with glaucoma, and I'm specifically referring right now generally to the category of primary open angle glaucoma, and not all the other secondary glaucomas or angle closure. But if we're thinking about regular primary open angle glaucoma, the first thing I think that you should do, and I think the gold standard now, the first intervention should be SLT. Secondarily, then you can start to introduce drops. Thirdly, and plus or minus cataract surgery in any of these steps. My third approach, if patients are not controlled or not tolerating their medications, is to consider some type of angle-based surgery, and that's usually either a GAT or a goniotomy, depending on my threshold for how much pressure lowering I want to get. Do I need the biggest bang for my buck? Do I need, if they're on several drops and they have very high pressures, then I'll do GAT. If they're modest to mild glaucoma, and I don't need that significant level of the maximum level of pressure lowering, then I'll consider a goniotomy. If I need to create a new drain, and I'm not sure I don't think Zen is available yet in India or any of the microshunts are, the cost of that is going to make it quite challenging in other healthcare systems. But in the US, my next step would be to do a Zen gel stent. And then if that fails, then I would consider a trab or a tube. Now, if the trabeculectomy fails, then I would consider an ab internal blood revision, which I'll talk about later. If that fails, again, at every moment of failure, you have to ask yourself the question, why is this failing? So if I do a trab and it fails, or I do a Zen and it fails, I have to ask myself, well, did it fail because of me? Did I do something I shouldn't have done? Did the surgery have some issue that I could have done better on? And if I did a trab and I didn't like the way I did my surgery, and I think that the surgery failed because of me, then I would consider a second trabeculectomy. But if I do a Zen that's perfect and the patient just scars down, then I'll say, hey, maybe the patient doesn't do well with subconj filtration surgery. I don't think a trabeculectomy would work here. I may just go straight for a tube. So I always think about every moment of failure. Is it something that I did, or is it something that the patient's eye did? And so then I do an ab internal blood revision. And if that fails, again, I ask myself, did it fail because the patient just doesn't like subconj filtration, or should I go back in? Maybe it worked for 5 years and then the patient had cataract surgery and then the trabeculectomy failed. Well, then I could probably go back in and repeat it. But if it looks like the patient just doesn't tolerate subconj filtration, then I will consider doing a tube. And if then the tube fails, and I'll talk about the data of this, I think the next step should be low energy ciliary ablation, low energy CPC diode. If that fails, then I will consider a second tube. And that really, in one slide, I've never done this before. This really is my general approach to how I treat glaucoma on a daily basis. So this is the GAT, and I'm not going to talk too much about that, but there's some videos on my YouTube channel that you can watch that if you. But it's really, I think, one of the most cost-effective methods for enhancing a patient's outflow system, performing an ab internal trabeculotomy with a Prolene suture. The Tonito goniotomy is a reusable micro hook that is basically has a left and a right, and it has a relatively low learning curve. It's cost effective. It's reusable, and it's an effective way to perform an ab internal goniotomy. And so here's some examples of a video of me doing the Tonito. And there's a left and a right and a straight. I kind of like the left and the right, but this is a left eye. I'm sitting temporal. You can see that you have two important things. I'm not going to talk too much about MIG strategies, but there's Helon GV on the cornea, Helon GV on the underside of my gonial prism, and that maximizes my view. And then you want to make sure you have a nice view of the angle. And then I'll basically, depending on the stage of glaucoma, I will treat maybe 3 clock hours, maybe 4 clock hours, maybe 5 clock hours. And so I'm going to treat to the left, and then I'm going to switch to the other hand, and I'll switch to the other instrument and then treat to the right. And you can see the nice white strip. That's the back wall of Schlemm's canal. You see a little bit of blood reflux. That's expected. But if you maintain your chamber, you don't lose your view. And now I'm going to go the opposite way to the right and open up. And here you're going to see I'm opening up at least 4 clock hours. And sometimes you see the trabecular meshwork bunch up just a little bit. But I want to make sure I have as much of the angle open as possible. And that's a nice post-operative view or post-surgical view of an open shelf. And so again, that's to the left is the temporal thing. Look nasally. Look in this nasal angle. You're going to see all these blood vessels blanch. And that's what I've described before as the episclerovenous fluid wave. So that's really a nice proof that the patient has an intact outflow system. Here's another example of a goniotomy with the Tenedo blade. I'm going to advance a little bit, but this video had patient's angle open up just beautifully. Really a nice open trabecular shelf. You can see that. And then this one had a nicer, a more visible, I'm going to advance a little bit, a more visible episclerovenous fluid wave. So here you can look to the left of the screen, right over here. You'll see as I inflate the eye, you're going to see all the blanching of the episcleral vasculature in the nasal quadrant, proof that the outflow system is intact. Again, one more time, you see that prominent vessel is going to go away, and proof that I'm shunting VSS into their outflow system, and we've correlated that with successful outcomes. So what do you do if you have a failed trabeculectomy? So back in perhaps in 2015, I've done an we developed an ab internal blood revision that I'll talk about. And this is a little spatula that we designed. Again, cost-effective way of doing that. It's a curved spatula for ab internal blood revision. And the tip is kind of thinner. The sides of the tip are a little sharp. The front part of the tip is more blunt, and that can help you bluntly dissect. And then when you go through, you can use the sides to kind of cut. And here you can see what you do. This is again, this is a left eye. I'm sitting temporal. I make a small paracentesis at 6 o'clock, 180 degrees away from the trabeculectomy. I use a traction suture. This is the most challenging part, is putting on a gonio prism and going into the sclerotomy site. You have to look upside down, flip your brain upside down, and reach across to make sure you get in the sclerotomy site. And then you bluntly dissect and unroof just the posterior aspect of the flap. And you can see I'm not getting an anterior flow. I'm just unroofing the posterior aspect of the flap, and you're getting the nice diffuse posterior bleb. I do this in patients that have a scarred flap bleb, or a patient that has had a trabeculectomy and failed angle surgery. Sorry, I had a trachelectomy and had a cataract surgery and then it failed, or they have a tenon cyst that I can't needle. It's important to use mitomycin C before, and I usually inject mitomycin C, usually 40 micrograms, depending on the appearance of the tissue, far posterior where I'm shunting fluid. So here's a video demonstrating that technique. Again, it's nice to use a traction suture, and this is the Ahmed gonio prism. You have to be able to visualize the sclerotomy site. And so I'll make a paracentesis about 180 degrees away from the sclerotomy site. And I'm actually doing this under topical anesthesia now. So intracameral lidocaine, and then put in Helon GV. And then I'll put the sclerotomy spatula through the hole, through the paracentesis. And then this is the key thing, and this is hard to do. You got to flip your brain upside down and look upside down. Look at the inferior mirror and make sure you visualize yourself going through the sclerotomy site. You have to make sure, otherwise you're going to create a iridodialysis or a cyclodialysis, and that's going to be a lot more problems. So in clinic, I make sure I can visually see the sclerotomy site. And then once I'm in the sclerotomy, then I gently rotate the globe down, stay there, and then I'll start to slowly, bluntly dissect just posterior. And it's nice that I didn't design this purposefully. It was just dumb luck. But because the spatula is blue, it really shines through, and so you can see it. And I've tried to do this with the cyclodialysis spatula. It's too short and it's too sharp. And you're going to see I'm just selectively unroofing the posterior aspect of the flap and going as far back as possible. There's usually two walls of scar tissue, one right away and then one a little further back. So you want to make sure you go through both of those walls. And then you can see that nice diffuse posterior bleb. That really gives you that ideal control and ideal blood morphology. Now you can see the open sclerotomy site more clearly. And then I put a suture through the wound. You want to leave some helon in the anterior chamber because the pressure is going to be low. So I'll leave some helon in the anterior chamber to keep the anterior chamber formed. And then you can see that nice diffuse posterior bleb immediately. And you want the pressure to be low, but you want it to be able to hold just a little pressure. And then I'll give them 20 to 40 milligrams of Kenalog as subtenon's injection and some subconj or intracameral dexamethasone, and then atropine. And then obviously they need to be on pretty strict precautions. So this is the kind of blebs you would see before. And these are the kind of blebs I see after. These are the trabeculectomy blebs we all dream about, the low diffuse posterior bleb without that anterior ischemia, just opening up selectively the flow far posteriorly. And so this is a before and after picture. And here's another example of a patient that I've done. Actually, the second time I did this to them, they failed after having cataract surgery, and I had to go back in and just selectively open up their posterior flap. We initially reported our outcomes on 21 eyes and 21 patients. Their average age of the bleb was over 6 years old. So these were trabeculectomies done a long time ago. A lot of them I hadn't even done. The average follow-up was almost a year. Preoperatively, their pressures, were 22 on 3.7 meds. And at 1 year, we got them down to 12 on less than a medication. 4 eyes failed. Maybe 5 and 1 was lost to follow-up, but would have failed. So 5 eyes failed. But 16 of those eyes did not need another surgery, didn't need a tube, didn't need another trabeculectomy. So I saved 16 patients from needing incisional glaucoma surgery. So again, leave helon in the anterior chamber, put them on atropine, give them Kenalog, be aggressive with their steroid use, and keep them on steroids until they're treated, just like you would do a trab. Keep them on steroids until their eye is quiet, and I slowly taper it down over a few months. And this is something that has been done before, but Dick Simmons reported this in the 90s. I didn't know about this, but he kind of did a different approach. He went through almost a central corneal incision, which I don't think is appropriate. You could really cause a lot of problems by doing that. And then he did the cyclodialysis spatula, which I used to do, but it's very sharp and it's not long enough, and you can cause a buttonhole and poke through the conjunctiva, which is not easy. So, we're moving away. I'm moving away from, and I'll wrap this up, I know I'm getting close, to size of tubes. And I actually do not do 350 Barvelts anymore. I actually can exclusively do 250 clear paths because I don't think size matters. And more and more data is showing that 250 and 350s are about the same, but I think the safety with 250s is superior. And more data is showing that when you compare a second tube versus low energy diode is safer and better than a second tube. So this is what I typically do. If a patient has failed a tube, I'll treat them for 4,000 milliseconds. My range is somewhere between 700 to 1,200 milliwatts, and usually 25 to 30 spots. And we look back at our data that we're about to publish, and we looked back at our 385 eyes. 200 of those had over a year follow-up. And this is people that have failed a tube shunt. They were on 23. Their pressure was 23.5 on 3.4 meds. And just with low energy diode, their pressures went down to 13.9 on 2 medications. And I had no evidence of persistent hypotony or inflammation. And I think this has revolutionized my standard of care. And I'm very rarely now do I put second tubes in the eye. I don't like micropulse, and that's a topic for another day. But I would strongly discourage you from doing micropulse. The data out there is becoming more and more concerning with safety. And so this is I treat my power settings are different depending on the patient's eye. So, if the patient is younger with a small tube, and on a lot of drops, then I'll treat 1200 milliwatts. But if a patient's older and has a large tube, then I'll lower my energy and lower my number of spot sizes. You don't want to get hypotony, so you can always treat more. But I would, if they have a large tube and they're older, I treat with lower energy. For all these instruments and everything, you can go to my YouTube channel and then contact Epsilon for any of the instruments. There's a trend towards interventional glaucoma. And I think early event intervention is important to get patients off drops. I think MIGS can be used in various health models around the world, and there can be cost-effective MIGS now. GAT, Tenedo, and the Ab internal blood revision are examples of cost-effective MIGS and can be easily incorporated into someone's surgical algorithm. This was just released. I wanted to we sat down, and we have authors from around the world, 26 to 27 chapters on our approach to GAT, and also just pontification of angle surgery and what's the future. And we've had experts from all over the world speak on GAT or write on chapters on GAT. And one of the discussants here, panelist Dr. Swati, wrote the book chapter on her experience with GAT in India. So we have good Indian representation in this chapter as well. But please read it or share it, because it really provides a really comprehensive summary on our, not just GAT, but our approach to angle surgery and outflow anatomy and the future of MIGS. But I want to thanks to Dr. Chitra and Dr. Murali for coordinating all this and being accommodating to my schedule. And thank you to all the panelists and the Eye Foundation. It's been an honor to speak to you all today. So thank you for your time.
Thank you so much, Dr. Grover. That was a wonderful talk, and I'm sure we have questions for you, and so would the expert panel. And and then I would look forward to you joining again for the last bit.
Yes.
Dr. Tanush Dada had already a question for you in the group. I haven't read it. Has anybody read it? Could we take his question first?
Yes. So it says the studies show how much of the trabecular meshwork do you operate on? Studies are showing that 180 and 360 GAT sometimes work about the same. I think there are there's two types of studies. Some studies are showing that a little bit more the angle you open up, the better the outcomes you get. And then there are some studies on GAT versus hemi-GAT. They're actually showing not significant differences. So I do think, I think if the less of the angle you open up, probably the less blood reflux you'll get, and the less hyphema that you'll get. So I think that needs to be evaluated further. But I think that is a good point, that if you have a patient that maybe is well controlled or just on a few drops, and you don't need to get the maximum effect of everything, I think a hemi-GAT would be very reasonable. But you have a patient, say for example, with pseudoexfoliation, their pressure is 30, they have advanced glaucomatous optic neuropathy, and they're on max meds, they have pretty advanced disease. I would still argue that 360 would probably get you a little bit more pressure lowering than 180. But again, that needs to be studied a little bit more. But I think it is a very good question and a good point that you could probably get away with opening less a lot of the times.
Dr. Pandav, I have a question which we saw the stepladder approach which Dr. Grover had kept. But supposing we have done a tube and it has not been very successful, would at any point of time you have an inferior tube, would you consider doing a superior trab before we go on to a cyclophotocoagulation or the second tube in the whatever sequence? Would you consider that?
I think we do consider that basically because I think MIGS are kind of a relatively newer, and if you go back, we have been following that again a step ladder approach, but there we did trabeculectomy and the tubes, and if it didn't work, and with cyclophotocoagulation, you have some concern about the vision, especially if the one-eyed patient was and when you're kind of afraid of losing the central eyelid. We have tried 2 tubes, and I think the literature suggests that the second tube does work. But I think, again, the second tube becomes a little much more invasive surgery, and that doesn't guarantee the success. So I think the success rate with first surgery is always better than the second surgery, whether it's a tube or is it trabeculectomy. But I think now we have that mixed space which has come in, but this is kind of not for that. The kind of glaucoma that where you would put tubes or advanced stage. I have a little question to Dr. Devinder. I think Devinder, very excellent and informative lecture, and I think thank you very much for giving your scheme of how you approach and how you define refractory glaucoma. I think that's very important, because what is refractory glaucoma? Because that would be different for a different situation. Does your plan change according to the phenotype of the glaucoma? Like, is it the same for PUAG or glaucoma associated with pseudoexfoliation or uveitis? And also on the stage of the disease, that how early or how late the patient is presenting to you?
Yeah, it does actually. I think it's a great point. And it's hard to generalize, in one slide, my approach to all glaucoma. It's crazy that we spend our lives treating one disease and we still don't understand it. So I think if patients have steroid-induced glaucoma, I think that the absolute treatment for steroid-induced glaucoma is angle surgery. So I wouldn't do a Zen, and I wouldn't probably do SLT, and depending on the stage, but I would have a lower threshold depending on the situation for doing angle surgery and steroid-induced glaucoma. And the same thing is true with pseudoexfoliation. If a patient has bad pseudoexfoliation, like you guys are very well aware of, and has phacodenesis or pseudophacodenesis, then I'm reluctant to do angle surgery on them because you can dislodge the lens. If you have zonular weakness, blood can spill into the vitreous, and that can be pretty devastating for the patient's vision. So if there's a significant amount of pseudoexfoliation, I want to minimize any, and there's a significant amount of pseudophacodenesis, I will minimize any manipulation in the anterior chamber. So those patients, and I also think there's good data out there that shows that trabeculectomies don't do as well in pseudoexfoliation. So in those eyes, I may be more prone to just doing a tube shunt. So it depends on the eye. If with uveitis or history of inflammation or history of diabetes, that's a pro-inflammatory eye as well. I don't think ciliary body destructive procedures are safe at all. So I'll be more likely to do a filtration or subconjugal filtration, like a trab or a tube. Blood thinners. If patients are on blood thinners and can't be taken off blood thinners, that's a big thing I take into consideration. And so yeah, and then also if they have early onset glaucoma, where I think they fall into kind of a juvenile open angle glaucoma picture, then I also will be more apt to doing angle surgery. Just to add on to the Dr. Chitta, the question you asked about angles after a failed tube, we did go back and reported our outcomes on GAT after failed trabs and failed tubes. And actually we had the failed tube group did better than the failed trab group when they had a subsequent GAT. But I do think that after a tube or after a failed trab, depending on the case, I don't think angle surgery is off the table.
Chitra, can I ask a question?
Yes.
Devinder, really exciting talk. And can you just tell me how exactly would you titrate a low dose, a low energy diode laser cyclophotovaluation? Because would you rather decrease the number of spots in a properly titrated higher dose normal DLCP that we do? Or how exactly would you titrate this?
Yeah, I really like the slow, low burn. It's kind of the way we describe it. So I don't like the high energy. I think that's very destructive. That pops. Like if you ever do ECP and you overtreat and you see a pop, I mean, it's very destructive. When you hear the pop, I mean, the ciliary body is literally exploding. And it's very inflammatory and quite destructive. So I like the low low energy pulse. 700 milliwatts is very low for 4 seconds. It's just a little destruction or making the cellular body just a little bit less effective. We're not seeing a lot of inflammation at all. I don't like to go higher than, typically I don't even go to 1200. I usually will treat anywhere from 800 to 900. But if the patient's older, their aqueous production goes down. So I will treat lower. If they have a large tube, like a 350 Barvelt or on 350 Adi, I will treat lower. So if you have a 350 Adi, in place. Then I would say start with, 700, 800 milliwatts. You can always treat more. You can't undo it. You can always treat more. So, start with 700, 800, and 4,000 seconds, and, play with it in your own hands. I can say without question, there's so much data out there that shows that low, slow, long treatments are relatively safe, and we're not seeing the kind of hypotony or inflammation that we classically associate with the larger doses and the classic CPC. So I'm doing these in eyes with very good vision potential, and they're doing quite well.
Dr. Murli, would you take one last question before we go on to our next set?
Yes, Dr. Davinder, I had a question for you. Just a hypothetical situation. You have a 97-year-old with a very advanced end-stage glaucoma, one-eyed, and with very severe ocular surface disease, has been on multiple medications for a very long time. And the patient very poorly tolerant to medications because of the ocular surface disease. So what would be your first, the pressure being, the Tmax is around 20 with almost end stage glaucomatous damage, and patient repeatedly developing corneal toxicity. So what would be your first line of management? Would you consider doing a tube or risk a trap because of the severe ocular surface disease? I mean, what would you?
Yeah, so it depends where I am, right? So, in the US, and that kind of eye, and I've done this obviously in patients, Zen works really, really well, right? Because you're not opening the conj, you're protecting against hypotony, the visual recovery is pretty quick, and it's almost, it can be done very quickly without under topical anesthesia, and the patients do well. I don't like doing a trabeculectomy in my 90-year-olds because the conj is so thin, and if they're on blood thinners, I don't remember if you asked, is this a one-eyed patient or two-eyed patient? But
one-eyed.
Yeah, one-eyed patient. I really like doing a tube shunt in those eyes. In my mind, the biggest risk of a tube shunt is double vision. And one of the most devastating complications is double vision. When a patient has one eye, that's not a concern. And so, what I would do in a 90-year-old is the pressure is going to go really low. So I'd actually trim the implant and cut off one or both wings. And those eyes sometimes, usually the 9-year-old patients, they're on blood thinners, so that makes it a little bit risky. And so typically in those eyes, what I like to do is I use a ripcord, where I tie off the tube with a 7/0 Prolene, and I use a 4/0 nylon ripcord, and I tuck that in the inferior quadrant. Okay, and that video is on my YouTube channel. That tube will not open until I open it. Right. So I don't want, and those patients, one-eyed patients, I don't want the risk the tube to open on its own and the patient to still be on max drops. I want to open the tube myself. So I will do it that way, have the patient come in, treat her on drops, until I waited at least 2 or 3, maybe 4 months, maybe 5 months, and then have her come in the office. I activate the tube by pulling out the ripcord in the clinic. I have her stop her glaucoma drops. I put a drop of atropine in the eye. I tell the family, hey, don't let the patient do any activity or heavy lifting for the next week. And I have a very controlled opening. And sometimes I just have them sit in my office for a half an hour, so I know the eye can just take it easy. The last thing you want to do with this one-eyed 90-year-old is have the tube open. She doesn't realize it. She's still on acetazolamide, still on max drops, and then she comes in and she has choroidal. So that's what I do with my one-eyed patients. I actually do that now with everybody, but I have a much more controlled opening. I don't like the tube opening on its own. It's too stressful for me, and I don't like not having that control.
Thanks a lot, Dr. Grover, for just a wonderfully amazing talk with so much clarity. And I know you have to get back to your OPD, but if you would stay on for some time with discussions, we'll be obliged. And please remember, you have to come back in the end. So keep your laptop open. So
Yes, I will. I will. So please just send me a text and I'll pop back in. Thank you.
yes, Murli will text you. Yes. We go on to our next group, the early trap failure. I'm going to just one-line introduction of our speakers and mentor, and I would just repeat the case summary, which has been sent individually to them, and then we go on to the talk. So we have Dr. Vanita Patakre, who's the current director of the Glaucoma services at Center for Sight Group of Hospitals in Hyderabad. And she's going to talk about MIGS would be the next step in early trap failure. We have Dr. Karthikeyan stepping in for Dr. Shikha just an hour back, a very brave assistant professor from RP Center. And he is going to be telling us on I would bet on tubes in early trap failure. And we are truly lucky to have Dr. Manavdeep Singh, who's a professor of ophthalmology from Postgraduate Institute of Medical Sciences, RML Hospital, New Delhi, who's going to be the mentor for this challenging case. The case summary goes this way. It's a 56-year-old male Indian with advanced open-angle glaucoma, primary open angle in the right eye on max medical therapy with an IOP of 24 millimeter mercury, poorly compliant, vision of 6/12. The left eye has been operated for phakic trap a year back. It has failed, and the patient is on 3 topicals for IOP control. Now, this patient has underwent a trabeculectomy in the right eye just 3 weeks back. And the bleb is flat despite massage. 5 few injections have been given. A releasable suture removal has been done. The ostium is open. The scleral flap is tightly opposed to the bed. There has been 1 failed attempt at needling, and the IOP now stands at 24 millimeter mercury on the 6th week. And Dr. Vanita Patakre is going to tell us why MIGS is the next step. On to you, Dr. Vanita.
Thank you so much, Dr. Chitra, and the Eye Foundation for giving me this opportunity. You made my life simple. Basically, this is the background that you gave me. But when a patient has had multiple interventions to control pressure in the early postoperative period, and pressure is still 24 in the 6th week, then in the real world scenario, this is what I would do. It's the least invasive method to move forward. Basically recommends anti-glaucoma medication with a prostaglandin analog. Of course, you have said he's non-compliant, so I would include intensive counseling, both by self and re-emphasized by my clinical counselor, as you see there. But let me also say that with the case summary that you've given me, there is some missing information, which I would like. This is presence or absence of cataract. What about the visual fields in that particular eye? I know you've called it advanced, but you know, how advanced? What's the VFI? What's the MD? And also, I would like the status of the fellow eye and whether mitomycin C was used during surgery. Now, nonetheless, let's move on. Let's talk about MIGS in early trap failure in advanced POAG. Of course, there is paucity of literature. There is the literature abounds with MIGS, but not specifically in early trap failure, and certainly none comparing MIGS with tube in trap failure. In the current scenario, therefore, rather than evidence-based, one has to sometimes rely on experience-based. But have a look at some of the pearls that I've found in literature. One is by Brevetti in KDB. Now, in this particular size, I'm going to talk about KDB. 12 months follow-up, 18% reduction of IOP in severe and refractory glaucoma with 32% reduction in AGM. Salinas et al. Have reported that to be 24.5 and 36% respectively. A review done by Cyril, multiple studies, but which only included 3 studies which had advanced glaucoma. He found that there was 12 to 26% reduction in IOP, and mean AGM decrease was up to 50%. I have looked at my own data, and this is, of course, very early, but this is moderate glaucoma. And I have found a reduction in IOP of 35% with a whopping 82% reduction in medication. Where GAT is concerned, Akhtas et al. Have looked into moderate to advanced glaucoma and have found a similar rate, 36.4 in a decrease in IOP, 64.7 in AGM. Wang et al. Have looked with failed incisional glaucoma surgery, but they were different types of surgery, not just trabs. And they found a 44% decrease in IOP, 86% decrease in AGM. Liu et al. Have looked at 4-year results. They have found 45% and 28% respectively, whereas a meta-analysis has found that the weighted mean reduction in IOP is up to 10 millimeter mercury, but it's less so in suture GAT. Weighted mean reduction in AGM was 1.68. Where iStent is concerned, there is one study I found which looked at an alternative procedure following failed trabeculectomy, and they did find 31% decrease in IOP, but not so much decrease in anti-glaucoma medication. We're all aware of this meta-analysis by Healy et al., where they have looked at G1 alone and have found a 31% decrease in IOP, about 7 millimeter mercury, translating to about 7 millimeter mercury, and weighted mean decrease in anti-glaucoma medication of minus 1.1. Of course, I have also looked at my own data. This, of course, I will say is in mild glaucoma. I have got a 20% decrease in IOP and a fair decrease in anti-glaucoma medication. Where trabectome is concerned, Sunita's study has been published. She's got about a 39% decrease with a 33% decrease in anti-glaucoma medication. A meta-analysis, on the other hand, has shown about 26% decrease in IOP with a 1.5 decrease in anti-glaucoma medication. Where ECP is concerned, in a surgically naive primary open-angle glaucoma, 3-year results. There are not so many studies out there in open-angle glaucoma with such a long follow-up. They have found a 26% decrease in IOP and a 48% decrease in AGM. I have looked at my data in open-angle glaucoma as opposed to angle closure glaucoma, and I have found a 36% decrease in IOP and a 60% decrease in anti-glaucoma medication. So if I were to put, and why I'm putting this across is because this is all Indian data, is that KDB as well as ECP produce 35% or more reduction in IOP with a more than fair amount of decrease in anti-glaucoma medication. iStent and Bang, on the other hand, produce about 20% decrease in IOP and a fair amount of decrease in anti-glaucoma medication. So in the scenario that you've given me, I have added these scenarios. If no cataract is present and glaucoma is moderate, then I would consider a KDB or a Bang or even an iStent. And let me give you an example of a case where the very first iStent in this country was done in a failed trab with
1 more minute, doctor.
multiple needlings. Sorry?
1
1
minute.
more minute.
Yeah, okay. Patient was on 5 topical medications, severely intolerant to it, and this was mild glaucoma. This is how he looked before, and this after he was, the toxic drugs were taken off. He had phaco eye stent in both eyes, following which he not only had controlled pressure on much reduced medication, but his eye also looked much better. So if cataract is present, and glaucoma is moderate, I would consider a phaco ECP. Again, if no cataract and glaucoma is present, moderate to severe, then I would consider a KDB. And if cataract is present and glaucoma is moderate to severe or severe, I would do what I call a combined, an inflow and an outflow procedure along with phaco. Let me give you 2 scenarios here done fairly recently. A doctor, 62-year-old, he was progressing. You can see his visual fields there post phaco and combined mix. Not only is his pressure controlled on no medication, his vision is also pretty good. And here's an extreme example where you can see the macular
6 minutes over, doctor.
When I look at combined MIGS, my data is 38% reduction with a fair amount of reduction in medication also. So the advantages, of course, is that they're small incision, all procedures ab interno, can be performed in topical, sutureless, blebless, lesser medications, very safe, rapid visual recovery, and better quality of life. And when you consider tube, of course, they can be expensive and there is a long post-operative recovery period together with a lot of complications. The list of complications do not stop. Therefore, if you want an eye looking like this at week 1, rather than looking like this at week 5, you need to consider. These are all tubes that take much, much longer to settle down to look like this. Whereas you also get these ungainly, unsightly blebs. This is the type of eye that you see when you do a MIGS procedure in a patient. So I would say MIGS is definitely an option. Control of IOP at low target can be achieved if you combine your MIGS, and need for tube can be deferred indefinitely or even avoided completely. Thank you very much. Sorry, I took a minute more.
Thanks, Dr. Vanitha. That was a wonderfully crisp talk, and do stay on for the discussion. I know you have to go back to your clinic. We go on to our next speaker, Dr. Karthikeyan, who's going to tell why he would bet on tubes in early trap failure. On to you, Dr. Karthikeyan.
So, thanks, ma'am, for giving the opportunity. Let us see the relevant history. So, advanced primary open-angle glaucoma patient. A patient, right eye IOP is 24 on maximum tolerated topical medication. Patient is pseudophakic and visual field testing, so advanced visual field loss. So already twice needling was done. So what are the options available at present? Either we can try the needling again, but already it's a failed needling. There is less chance that it can be successful. Needling will be successful only when the bleb is localized or encysted. Another thing is minimally invasive glaucoma surgery. And is retrap. Next is glaucoma drainage devices. For going on to minimally invasive glaucoma surgery, for the to look for its success, first we have to know the check for the angle. How is the Schlem's canal? We can do it through ASOCT, and we can the character channels we can use aqueous angiography to identify them. When do we do minimally invasive glaucoma surgery, and when will we do trap? If the patient is having moderate glaucoma or moderately high pressures, we'll prefer a minimally invasive glaucoma surgery. But when the patient is having advanced cupping and very high pressures, like in our cases, we would prefer glaucoma drainage devices. And in ASOCT, there will be absence of Schlem's canal or absence of collector channels or Schlem's canal in aqueous angiography. So in this image, you can see A image is a high pressure open angle glaucoma in which Schlem's canal is not visible or collapsed. In the B image, you can see a control eye in which Schlem's canal is clearly visible. This is a aqueous angiography mapping. Aqueous angiography shows in a control eye, it shows the Schlem's canal and the collector channels easily visible. In patients with high pressure primary open angle glaucoma, very few collector channels and Schlem's canal are visible. So in a patient with primary open angle glaucoma, if target IOP is not achieved on medication, initially we can plan minimally invasive glaucoma surgery like goniotomy or GAT. If not successful, then initially we'll plan with we'll plan with TRAB with MMC. If failed, we'll give a trial of needling. If not, then we can go for glaucoma drainage devices. This shows Schmidt et al. Shows the outcome of GDD AGV in his retrospective study at 24 months after failed TRAP. in POG patient had a 75% success rate. And UG et al. In his retrospective study showed a 5-year success rate was approximately 50%. My take is GDD will be a best option for failed traps in who is having advanced glaucomatous cupping and patient is if the patient is pseudophakic. Like and for minimally invasive glaucoma surgery, all the results we have is just for 1 year or 2 years. We don't have long-term outcomes like 5 years or 10 years to say it will be really useful in these cases. Thank you.
Thank you. Thank you, Dr. Karthikeyan. Dr. Manavdeep, would you be able to discuss it? You have 5 minutes.
Hello.
Yeah, yes, doctor.
See, I think the most important thing in whatever intervention do is the level of the comfort of the surgeon. What we normally read the studies about are by the surgeons who are most comfortable with those kind of surgeries. So they are successful in those surgeries. So what we need to understand is whosoever is a surgeon, that surgeon has to have his level of comfort for that kind of surgery. That is number one. If a person who does routinely every day he's doing tubes, you put him to do bigs or vice versa, it's not going to succeed. Second thing, I think 3 weeks post-operatively is too early to intervene. One should try mitomycin C eye drops in these cases who are failing. I would not call it failed. 3 weeks is failing. It's a failing surgery. It's not a failed surgery. We can try ab interno manipulation of the bleb revision, and then we can start. Even without doing that, we should be able to. Let me tell you, I have got a lot of experience of using both 5FU eye drops, 5FU injections, and MMC eye drops. MMC eye drops, 0.4 milligram, 4 times a day. They are far more, successful than the 5FU injections. The era of 5FU is gone. And as far as in case you have to do intervention, you feel suppose it's 5 weeks, 6 weeks, then of course, I feel if a person has cataract, then you can go ahead with cataract surgery and then followed by tube if required. And in case the patient is pseudophakic, again, tube is a preferable option because again, mix is likely to fail in a short period of time. However, if a person is very comfortable with mix and the patient is phakic, then of course mix can also be considered. But I think the most important thing is the comfort level of the surgeon. And secondly, I want to repeat, this 3 weeks is too early to intervene. Thank you.
It wasn't 3 weeks, it was 6 weeks, but patient was not on any medication. And that is why I feel that doing a tube is excessive. Definitely doing a valveless tube in a situation like this, you are going to end up in intractable hypotony and you may have to take off the tube. So we're talking about a particular situation. And unfortunately, I think my opponent did not look at that situation in details and gave a very generalized nomogram of how to manage POAG. But nonetheless, I feel that maybe even though I have presented on MIGS, and yes, even though I do a lot of MIGS and I also do a lot of tubes, I will say that in this scenario, my first choice would be to start a medication, a prostaglandin analog for that. I do not want a drug that reduces aqueous production. I want a drug that increases outflow.
Yes.
I agree with you that because I think, again, as I said, it's too early to intervene.
Yes. Dr. Shushmita, are you there with us? Dr. Shushmita? Yes.
Yes, Dr. Chitra.
Yeah, I wanted to ask you, since it was at that 6 weeks when the patient was seen with 24 millimeter mercury, one needling was done. So how soon would you have needled this patient and how many needling would you do before you think of the next step?
So I agree with Dr. Manavdeep saying that 6 weeks is too early to surgically intervene. We do tend to try and open up outflow and massage vigorously. The way we massage it is ask the patient to look straight and massage in the center of the cornea under closed lids. And many times that works. The other thing that happens at 6 weeks, which is important to understand, is that there's a hypertensive phase, which means there is actually excessive outflow and the channels are getting squashed, so to say. This is Dr. Robert Rich's teachings. And actually at 6 weeks period, that hypertensive phase requires aqueous suppression so that it doesn't become a tenon cyst. So it's important to recognize the hypertensive phase. Then if it's a very hard looking bleb, what they actually need is aqueous suppression for about 2 to 3 weeks, and more often than not it will settle. We do a lot of needling. I use 5FU. Somehow I'm a little uncomfortable with using MMC drops with all the cornea colleagues telling us of the dangers of scleral melt. But yes, we would do a 5FU, and it is not dependent upon the pressure. It is dependent on the corkscrewing and vascularity of the bleb. So we would do it as
add here that the bleb was actually not high. In fact, the bleb was flat. The background information was very specific.
Okay. So Chitra, I think both of them have given gems.
Beautiful gems.
Yeah. So Vanita was very right in saying that initially we just have to start medication. And Chitra very rightly said that obviously we can try further needling and 5FU. And Manavdeep was so right in saying that yes, you let the surgeon do what is to be done. That is true for every case, because very, very few people are comfortable with at current situation in India.
Yes, wonderful. Dr. Shanta, one last question I would ask before we go on to the next section. Now, you know, at 3 to 4 weeks, you see that the bleb is actually flat. Incidentally, not exactly this case, any general case, and it lifts well on massage. So how are you going to manage that particular scenario, which many of us see happening? The patient comes with a flat bleb and it lifts on massage. So what would be your steps which you would tell all of us speakers and audience?
Well, generally at 4 weeks, if there is a good IOP drop with massage, I would hesitate to do anything else. Yes. It would depend on the amount of mitomycin you've used, the duration of application, how old the patient is, the target IOP that you require. But if the IOP comes down with massage, you can just continue that for about another 2 to 3 months also. Okay. And if you have a remaining suture in place, you can do a laser suture lysis even up to 2 months, even 3 months after the surgery. But each time before you attempt removing the remnant, the last suture, which is in place, it's always better to advise a massage, see how much of a drop in IOP you get, and then remove the last suture. Because we've had overfiltrations even 2 months, 9 weeks following the surgery. So if you take these steps, I think it should be more than adequate. We underestimate the effect of digital massage when antimetabolites have been used. It works well.
Yes, wonderful. That was a wonderful take-home message. We shall go on to our next group of talks, and Murli, stay awake. You have to read the summary there. So we have Dr. Mayuri Kamar, who is a senior glaucoma consultant at Akura Eye Care and Research Center, Ahmedabad. And in late trab failure, she says that re-trab is the way to go. We have Dr. Ronnie George following in, who's the deputy director at Shankar Nethralaya, Chennai, again, a very esteemed glaucomatologist, and he's going to tell in late trap failure, GDD would be a safe bet. And we have Dr. Mahesh Bharti chipping in here. He's a consultant glaucoma services at Ahalya Foundation, Palgad, after a long stint at LB Prasad. And he would tell that he would bet on minimally invasive glaucoma surgery. So we have 3 ways of looking at the late trap failure. And we have our prestigious expert panel, Dr. Lingam Vijaya, who is going to mentor it. So, Murli, can you rapidly read the case scenario and we go on to the 3 set of speakers?
Yes, yes, madam. So we are dealing with a patient who has late trap failure. So here we have a 60-year-old female Indian with advanced pseudoexfoliation glaucoma, had undergone phacotrabeculectomy in the right eye. The left eye also has pseudoexfoliation, no evidence of glaucomatous optic neuropathy, and has a clear lens. So the trabeculectomy in the right eye, phacotrabeculectomy in the right eye was done 5 years back. The IOP is controlled with medications for 4 years and the vision is 6/6. Past 6 months, she's on topical brimonidine timolol combination. Started as the Tmax was around 22 millimeter of mercury, bleb microcystic. Was switched to brinzolamide timolol combination, and timolol was withdrawn after an episode of myocardial infarction with congestive cardiac failure. Patient is presently on travoprost and brinzolamide. The IOP is 15 millimeters of mercury. Complaints of congestion with prostaglandins has been irregular on review and medication, and would like to be medication free if that is possible. So over to you, Dr. Mayuri.
Dr. Mayuri? Dr. Mayuri, you are not heard.
Unmute yourself, Dr. Mayuri.
Am I heard
Yes.
now?
Yes,
Yeah.
yes. That's
So
fine.
I will be talking on the late bleb failure. Retrab is the way to go. This is the case summary that has been read to you. 60-year-old female Indian with advanced pseudoexfoliation glaucoma who underwent phacotrab in the right eye 5 years back, with other eye almost normal, except pseudoexfoliation. And I will be going through this each point during my talk. Glaucoma management principles basically starts with the medical therapy, then the laser, trabeculectomy and MIGS can be in the same patient, and then comes the drainage devices and other options. Now, when an initial trabeculectomy fails, the issue of the best management and the choice of second procedure presents itself a problem. The decision is often between the glaucoma drainage device and the repeat trabeculectomy. So what are the points I would like to consider prior to the second surgery? Age of the patient, time since the last trabeculectomy done, conjunctival status, number of medication that patient is on, lens status, and comorbidity, which could be ocular or systemic. Now, this is the case scenario that we have. We have a 60-year-old female patient. Phacotrab was done 5 years back, but for 4 years, patient was medication free. Conjunctival status supposed to be good as she has a microcystic bleb, which is a functioning bleb. Number of medications are 2. Patient is well controlled with the 2 medications, but suffering with the side effects like congestion with various drugs. So intolerance to the many drugs. It is a pseudophakic eye, and left eye has a clear lens with the exfoliation, but no glaucoma. And the other comorbidity, systemic comorbidity, is patient has MI with CHF 6 months back. So second surgery to be, patient wants second surgery to be medication free. So we have phacotrab done 5 years back, qualified success is there, microcystic bleb with the good conjunctiva is there, but patient has MI with CHF 6 months back, with commensurate with pseudoexfoliation. So at the age of 60, now these patients, I will quote the study, which shows that there is a limited lifespan. Maybe life expectancy 5 years or little more. And this is various studies in the literature which shows that the lifespan reduces with this comorbidity. Now, success rate of retrabeculectomy is also proportionate to the age of the patient. It is identical in both pseudoexfoliation and POAG cases as a primary surgery, as well as with the repeat trabeculectomy. So 2 years outcome of repeat trabeculectomy with mitomycin C in primary angle glaucoma and pseudoexfoliation glaucoma is shown in this study, and 3 criteria were for the success for absolute or relative success were defined, and the success rate was quite high in the criteria A, or even at the criteria B, less than 18 millimeter of mercury, or the reduction of IOP more than 30%. And 2 years after repeat trab, the mean IOP was reduced successfully by 38.8%. This is our Indian study, which has shown the outcome of repeat trab with the mitomycin C in isolation or in combination with the phacoemulsification. And they have also shown that the repeat trabeculectomy with MMC is successful in lowering the intraocular pressure and decreasing in the number of the anti-glaucoma medication at the end of 1 year. Now, the question comes whether to do the retrad at the same site or versus different site. So this is the study which is showing the same site surgical revision of the failed trabeculectomy bleb, and our patient has a good microcystic blood. So we can choose this option also with the augmentation of mitomycin C. And the long-term follow-up of this study has also shown the very good success rate, absolute success as well as qualified success rate at the end of long-term follow-up. Another study, same site revision, and they have also come out with the outcome and risk factors for the failure. And they suggested that if we do the resurgery within 3 years, then the success rate reduces. Now, retrap versus TEF, only one slide I will share here, as I am also doing TRAB in many of my cases, but in this particular case, why retrap? So the repeat TRAB versus mitomycin C, with mitomycin C versus Ahmed glaucoma valve implantation, they have selected 1,305 studies of them. Analysis of 14 studies were done. The mean IOP was not significantly different between the two groups preoperatively, and then after 1, 2, and 3 years follow-up was done. And the number of medication between two groups were also similar preoperatively, and they found out that the cumulative site-threatening complication was significantly higher in Ahmed valve group. Repeat TRAB may be a preferred method, and it provides similar efficacy with the fewer disadvantages. So in end, I would like to conclude that TRAB is an established procedure. Everyone is habituated in doing this, no learning curve, possible to detect early failure, and you can salvage this TRAB bleb by office procedures like needling or 5FU or drops, and options are limited after tube fails. And the cost is also a factor in other two options. Thank you very much.
Thanks, Dr. Mayuri, for putting it so beautifully together. On to you, Dr. George.
Thank you for the kind invitation, and I'll just... So are my slides visible?
Yes.
Yeah, so the case has already been described, and I will not
Yes.
go into any details. So the rationale for doing a glaucoma drainage device in this patient is basically that one surgical technique has failed. Why do you want to repeat it? Because it is the repeat technique also has the same risk of failure in somebody like this. So I'm going to share with you the same paper that Dr. Mayuri just did, and this was our own outcomes of repeat trabeculectomy in 113 eyes. The mean duration post first TRAB was 4.1 years, very similar to this case that we're discussing. And the mean number of medications was 2.9, again, not very different from this case that we're discussing. While she showed you the success rates for only the POAG cohort, I'm going to show you the success rates for all the types of glaucoma that we had here. And the complete success rates that you're looking at there are about 60%. And this is without criterion of IOP of less than 21 and at least 20% intraocular pressure reduction. All of us will agree with the type of glaucoma that this lady has. We are looking at much lower IOPs than 21. So you're looking at an IOP of, this is criteria B or criteria C, and there you're looking at just about a 40 to 50% success rate. So I'm going to just look at probably the first study which looked at these two, parameters, the tube versus TRAB study, and see what we looked through it. So it looked at patients who had undergone tube versus TRAB in MMC versus, and patients either had previous cataract surgery or a TRAB with or without an antifibrotic agent. And the time from primary surgery here was again 54 to 60 months in both groups. Again, a little more than the patients that we just saw. And this is what they did, and they had fairly reasonable follow-up. And what you see over here is their criteria for success here are very similar to the criteria for success that are criteria A that I showed you. At year one, success rates look, the intraocular pressure looks similar. But what's important is the success rate, and the success rates are about 85% in the TRAB group and close to 97% in the tube group. And the reason for this is the moment you start looking at the hypotony rates in the TRAB group, your success rate drops. So they reported much higher rates of complications in their TRAB group. At 1 year, intraocular pressure reductions again similar. This is again partly because you've included the hypotenuse eyes. At 3 years, IOPs are very similar, but success rates are again markedly different, about 70% in the TRAB group and about 86, 87% in the tube group. again related to the hypotony rates that you saw with the trabeculectomy. So 3 years again, you can see not very much difference in the intraocular pressure between both the groups. IOP less than 15, you're still looking at about 50 to 60% of patients having this type of an intraocular pressure, which is what we need in this lady. At year 5, trabeculectomy group and tube group, again, not very significant differences in terms of intraocular pressure. In terms of success rates, the trab is down to under, about 65%, a little less than that, 55%, and the tube is sitting at about 75, 78%. So as you go along with time, the success rate does come down, and this is with fairly modest numbers that we're looking for. And IOP less than 15 years at year 5, you have about 65% of patients in both groups. Now, Dr. Mayuri said that this patient's life expectancy is likely to be about five years. But we know that with improved technology, life expectancies are dramatically increasing in patients who require cardiac care. And with the low target IOPs required in this lady, I would not really consider doing a trab as a primary option. And what you see over here is on the left, you see the slide which shows the failure rates of the tube group over time. So from a 100% success rate at baseline, obviously close to 100%, it drops to something like 50%. For the tube, the same numbers, for the trab, the same numbers go from about 92% to close to 40%. And the green line at the bottom shows you how the failure rates are steadily increasing in both groups. Complete success rates are lower on both sides, and that's because obviously many of these successes are mentioned for patients who are on additional medication in addition to the surgical procedure. And if you look at this red line, which is showing you the 5-year success rate for trab, you can for the tube, you can see that the trab success rate is much below that. So what is the likely whole story of the failed bleb? And this is not only for this patient, this is in general. The trab starts failing, you do an intervention, you might consider needling, you might consider something else, you add 1 drug, you add 2 drugs, you add 3 drugs. So the failure, even though this trab, you started medication at year 4, probably started 6 to 8 months before that. And that is not very long after a trabeculectomy. If the patient is going to show the similar sort of a profile on a second trab, you're likely to see failure not at year 3, 3.5, you're likely to starting to see failure at year 2, 2.5, and you're going to struggle to manage it. And that's the reason I feel we need to do a glaucoma drainage device in this patient, because that is what is most likely to be able to take care of her going forward. Thank you.
Thank you, Dr. George. That was a very crisp way of giving the answer. And we go on to Dr. Mahesh Bharti.
My slide visible, ma'am?
Yeah.
Okay. Good evening, everyone. Thank you, ma'am, for the opportunity and considering me worthy enough to talk on a topic which is nascent. And primum non nocere. First, do no harm. In glaucoma, I would like to translate this as do as minimally invasive as possible. And the whole aim of glaucoma management is to do as minimally invasive as possible to postpone the need for more invasive intervention to delay the visual loss. This is an excerpt from an article which was published 10 years back. And here it says, cyclodiode ciliary body ablation, repeat trabeculectomy at a second site, formal revision of the existing trabeculectomy, and drainage tube implantation may be considered in a failed trab. This was the scenario then. Fast forward 10 years, the current scenario where we are discussing the possibility of MIGS being an option itself in late bleb failure is a win-win situation for the procedures and the devices. And the availability of literature to substantiate this claim is encouraging. Moving on to our case, I'll just point out the favorable scenario. It's a secondary open-angle glaucoma. It's a functional bleb, but with reduced efficacy. The IOP is controlled with anti-glaucoma medications. To notice, the patient is having heart disease. She's allergic to PG analogs, also irregular with medications and follow-up. So the aim of intervention is to do some intervention which will be an adjuvant to the functional bleb. and target IOP of early teens, decrease the dependency on medications, and achieve all this with less follow-ups as the patient is suffering from a cardiac ailment. Is MIGS worth considering? Let's delve into this topic considering the efficacy, safety profile, quality of life, and cost of treatment. About MIGS efficacy, my presentation is not very different from Dr. Vanita's. The quotes are also almost the same studies. Here I quote Dr. Grover's publication on efficacy of GAT post prior incisional glaucoma surgeries. And it is interesting to note that the patients had prior trabeculectomy, 13 patients had a prior drainage device, 4 patients had a prior trabectome surgery, and 5 patients had a prior endocyclophotocoagulation. And at 2 years follow-up, GAT appeared to be safe and successful in almost 70% of the open angle patients. About the efficacy of ab interno trabeculectomy with trabectome, the Kaplowitz et al. Group, they achieved a decrease in intraocular pressure of 39% and almost decrease in AGM by 2 medications. The efficacy of iStent, as published in European Journal of Ophthalmology, the results showed a significant intraocular pressure decrease by around 25%, and the post-operative decrease in AGM was about 2 medications. Goniotomy using the Kahoot dual blade, the proportion of eyes achieving an IOP reduction was more than 20%. So about the efficacy, it is well established in mild to moderate glaucomas, and in even advanced glaucomas and also with prior incisional surgeries, the efficacy is around 25 to 30% reduction in IOP from baseline, 1 to 2 AGM reduction from baseline, success rate of more than 50%, and mean survival period of minimum 2 years. Going on to establishing the safety of MIGS. Do you want your eye to be seen like this or like this? With a chance of tube exposure, implant exposure, a bleb leak, or a bleb associated endophthalmitis? Choice is yours. MIGS is a conjunctiva sparing procedure. The most commonly encountered side effect is transient hyphema and transient IOP spike. We talk about learning curve. When ECC and SICS was the norm, we took the pain to learn phaco, and today phaco emulsification is the norm. As Dr. Mayuri said, there is no learning curve in trabeculectomy. Yes, there is no learning curve, but if you see the acceptance of MIGS now even in the Indian scenario, more and more surgeons are learning it and learning it faster. About the quality of life and cost analysis. While the major disadvantage often cited is cost, there are different options and opinions about the overall cost efficiency of MIGS procedures when compared with standalone filtration or shunt surgeries or combined with cataract extraction. This is an excerpt again which says that MIGS is less cost efficient than traditional glaucoma surgeries and
One more minute, doctor.
Yes. But the economic burden of the disease, the cost of medical therapy, cost of frequent follow-ups, loss of wage during these follow-ups, and the quality and disability adjusted life years of these patients remain an area of interest for public health specialists and economists. The current mix available options in Indian scenario are the iStent, iStent Inject, GAT, the bang procedure, trabectome, ECP, the transcleral cyclophotocoagulation, low energy or micropulse, and the ab interno canaloplasty. My take clinic message would be MIGS procedures are minimally invasive, moderately efficacious, highly safe. Fewer post-op medications and visits will definitely improve the quality of life of the patient. Surely has a place in suitable patients to postpone the more invasive procedures. And I would like to request the audience to embrace this new kid who is no longer new with open arms and help it grow. And about tackling the cost, like we have the inventions of suture GAT as against the microcatheter, bang against the KDB, Or rather than citing cost as an hindrance to accepting MIGS procedures, we should work towards how these procedures can be added in the existing insurance coverage for patients' benefit. And finally, I would like to make a statement. The question should not be whether MIGS or other procedures, rather it should be which MIGS to be used. Thank you.
Thank you. We've had three wonderfully crisp talks projecting for each of their arguments, and we look forward to Dr. Vijaya mentoring it. On to you.
Thank you, Chitra. As expected in field of glaucoma, three different opinions about the same scenario. I'm not surprised. So I just briefly start with Mayuri's presentation, and that is a trabeculectomy for the failed trap. If you ask me, the first chance is the best chance. So whenever we do the trabeculectomy, the aim is to make sure it will work for the longer period of time. Since it is around 4 years of time, and you have pointed out possibility of the revising the bleb. Yes, when you have done a trabeculectomy with the mitomycin C, even with a late failure, it is worth revising that bleb, not to give up on it, as long as the stoma is patent. And what generally we do is we take them to the theater under topical anesthesia, where we inject the oculum, inject 0.04 milligram per ml of mitomycin C, that is 0.1 cc. And after 10 minutes, we do the needling part and try to salvage the existing bleb. So your arguments were well taken, but I still feel you should never give up on a patent stoma where the scarring is the cause for the failure of the trabeculectomy before going for the second surgery. That's purely a kind of an option I'm suggesting. So coming to Ronnie, I think he has presented beautifully. And if you look at all the slides he presented from TVT, it's all based upon the larger plate, that is the bar welt, not the AGV, that you have to keep it in mind. What is important to remember, if you see ABC study, if you go for the AGVs, you tend to develop the higher pressures with lesser complications. If you go for the bar welt, you tend to develop low pressures with higher chances of the hypotony. He has beautifully presented it. It is an option. As rightly Mayuri has put forward, if you do a bar welt in one quadrant, if it's superior temporal, doing the retrabeculectomy is out of question. If that fails, you have to go think of other options. And also remember, in spite of the large plate, you are likely use glaucoma medications. They can never be free of glaucoma medications. So again, patient will come back to that poor compliance, difficulty to use the medications, contraindications, everything will come into place. So I want to re-emphasize, in a clinical situation like this, yes, both options are perfectly acceptable. I would suggest what works best in your hand is the best for the patient. Coming to the mix, I have a strong objection, even though in literature it has been accepted to include ciliary ablations, especially transscleral ablations, as mix. It doesn't make any sense to bring in transscleral ablation into the mix, even though the literature started kind of accepting that because it is minimally invasive. It is comparing apples with the oranges. If you look at the spectrum of the options for the management of glaucoma, where does the mix come? It comes between the medication and the conventional surgeries. When the conventional surgery fails, you have to be very careful in going ahead and trying to offer the mix. Again, it depends upon what the clinical situation is, rather than iStent, I don't think will work. The same way KDB, I don't think it will work for a longer period of time. I think one has to be careful. Mix has a place, no question about it. But is it after the trabeculectomy? I doubt it. Thank you.
Thank you. That was wonderfully put together. Murli, you can just one question. Yes.
Chitra, one point. The
Yes.
pseudo exfoliation patients, the trabecular meshwork is also not that healthy, and even this atresia of Schlemm skin.
No, Mayuri, pseudo exfoliation is one of the indications for the mix. It is
No,
not.
but after re-surgery, the MIGS I'm talking about. Will it work in this?
I mean, MIGS is not a pseudo exfoliation is not a contraindication for mix. So, but I have a strong objection. I think we have to discuss it maybe in bigger forums to talk about transscleral ciliary ablation as mix. It's not correct, if you ask me.
Only you can take one question with the expert panel and we have to go on to the next section right away.
Yeah, I have a question for the surgeons who are doing KDB or bang. Let us say you have deroofed 180 degree of the Schlemm canal and the procedure has worked for some time, let us say a year or so, and then the pressure start rising again. Would you go back and treat the other half of the trabecular meshwork with either KDB or bang or trabectome for that matter?
How will you approach it? You can only approach the nasal with the KDB. How will you access your temporal incision?
You can sit nasally to approach the temporal, nasally to approach the temporal line.
How will you, where will you sit?
But your approach over your nasal bridge is not at all possible to introduce devices to.
Very difficult.
No, the reason why I asked this was because whenever the suture stops and we have to do a goniotomy, that's how we do a goniotomy. We sit on the nasal side and approach the temporal line. We'll do a goniotomy and retrieve the suture. So
I have a comment. When you consider the fact that you're trying to increase outflow to the collector channels, most of the collector channels are on the nasal side.
Exactly.
So I don't see the option of doing it temporarily. A repeat procedure.
Right.
So I think I agree with Dr. Vijay. I think in the initial part of the comment, because an a trabeculectomy which has functioned for 4 years, and as late failures, now that bleb is actually a well-established bleb, and for some reason it has scarred down. Now the scarring usually is not very bad scarring, is a very subtle scarring which has led to delimitation of the bleb or something like that. And these are the blebs which are very easily amenable to procedure like needling and external or maybe internal, but mostly they are very easily amenable to external needling. And I would say that I would do a needling for this situation before I try anything else. I think, and Dr. Vijay has already explained how she does it.
Yeah, truly makes sense. Thank you so much. We go on to our next section, which is take it or leave it, primary angle closure glaucoma with early cataract. We have Dr. George Putran, who's the Chief of Glaucoma Services at Aravind Eye Care System, Madurai, and he's going to be talking on I would proceed with a combined surgery. We have Dr. Subhashini, who's the head of the Department of Ophthalmology, Glaucoma and Cataract at JIPMER, and she would be talking on I would leave the lens alone. And we have mentoring the two, Dr. Surinder Singh Pandav. And the case scenario is like it's a 45-year-old female with primary angle closure of wherein there's more than 270 degrees of the angle is closed after a YAG PI. Patient is poorly tolerant to medical therapy, systemic comorbidity, allergy to brimonidine, but the vision is 6/9 and the IOP is 25 millimeter mercury. Am I heard? With 25 millimeter mercury with moderate glaucomatous damage. And you have been planned for a trabeculectomy procedure. Should we combine it with cataract extraction or not? And the fellow eye is 14 millimeter mercury with a mild glaucomatous damage on single medication. So we go on to Dr. George Putran.
Good evening, everybody, and thank you, Dr. Chitra and Murli, for this opportunity. So just to put things in perspective, we have primary angle closure glaucoma with early cataract, post-YAG PI, and it looks as if both of us have agreed, both me and Professor Subhashini has agreed that we have to do trabeculectomy here. So the question is, should we combine it with cataract extraction or not? Okay, all of us know that primary angle closure glaucoma eyes have shallow anterior chambers, thicker lenses, and they are more anteriorly positioned. And effect of cataract removal in a primary angle closure glaucoma, it deepens the anterior chamber, widens the drainage angle. There is a reduction of intraocular pressure and prevention of progressive angle closure or reclosure. So the main objective is in this scenario would be to reduce intraocular pressure, preserve the glaucomatous, preserve the optic nerve head, and also to open the angle. Trabeculectomy alone has the potential for an anterior shift in the lens position, exacerbating the angle narrowing. There is a lot of evidence in literature that eyes with higher lens vault, a narrower trabecular iris space, a shallower anterior chamber depth, and a narrower anterior chamber angle were more likely to achieve greater angle opening and greater IOP reduction after cataract removal. This is another OCT picture, pre and post cataract extraction. The lens vault is approximately, which is about 4 to 5 millimeter, becomes less than 1 millimeter in the pseudophakic eye. Another very important publication from the report by the American Academy of Ophthalmology, where they state that phacoemulsification typically results in a small, moderate, and marked reductions of intraocular pressure and medications for patients with POAG, PA closure glaucoma. Again, another analysis which again shows that the pressure reduction with cataract surgery in angle closure glaucoma is much more significant. Lower intraocular pressures are achieved with phacoemulsification in eyes with narrow angles compared to the open angle glaucoma eyes. So in trabeculectomy in primary angle closure glaucoma, trabeculectomy alone in primary angle closure glaucoma is high risk of failure because there is a postoperative anterior, there can be a postoperative anterior chamber shallowing predisposing to malignant glaucoma. Choroidal effusion hemorrhages can be common, hypotony, and cataract formation and progression. All of us know that whatever precautions we take, pre-operative aquasuppressants, IV mannitol, slow decompression of the eyeball, even an anterior chamber maintainer, in a phakic eye, an angle closure glaucoma eye, doing a trabeculectomy, till we put the apical suture and form the AC, it's almost a heart in the mouth existence for the surgeon. There's another study, trabeculectomy in primary angle closure glaucoma. Followed up for 5 years. 6.6 patients became blind from hypotonic choroidal detachment, hypotony, maculopathy, and bullous keratopathy. And there was a higher incidence of blindness during the first 18 months after surgery. Case in point today, it's not only about reduction of intraocular pressure, it's also prevention of progressive angle closure or reclosure and reopening the closed angle. So you achieve a reduction of intraocular pressure with trabeculectomy, you achieve a reduction of intraocular pressure with cataract extraction. You also have the added advantage of reopening the closed angle, prevention of progressive angle closure and a reclosure. And again, you can avoid the shallowing of anterior chamber and progressive angle closure with cataract if you do a cataract alone. This combined surgery indicated in primary angle closure glaucoma, most of the studies in literature, cataract surgery alone significantly reduces intraocular pressure, deepens the anterior chamber. We do a combined surgery in specific indications, like what we have, what the scenario was given to us today, IOP not controlled with maximum medicines, is intolerant to medication, and there's risk of progression. I tried looking into available literature for a direct comparison between trabeculectomy and combined surgery in primary angle closure glaucoma, and I found what I suspected. Every other publication compares cataract surgery with phacotrabeculectomy in angle closure glaucoma, and there were innumerable ones. I was not able to find any significant literature which compared trabeculectomy combined with phacotrabeculectomy in angle closure glaucoma. What are we worried here? Are we worried about complications of cataract surgery in this scenario? Believe me, the intraop challenges and risk of complications during cataract surgery increase exponentially in an eye with PACG status post-trabeculectomy. And I'm not even going to discuss about the quality of life or the cost benefits involved.
1 minute left.
The case in point today, was actually the scenario given to us would be, I would proceed with a combined surgery. Here, there is no controversy at all. Actually, the controversy would have been if it would have been, I would do cataract surgery alone here, and if necessary, plan a fail filter later. And this publication, it's a major review in the Survey of Ophthalmology, put things in perspective. A lot of things which we surgeons have difficulty in on-table, post-operatively managing trabeculectomy in primary angle closure glaucoma. And these are my acknowledgements for the day. My colleagues, Dr. Kavita and Dr. Shruti at Aravind Hospital. Thank you very much.
Thank you, Dr. George, for a wonderful talk, as I always expected. We go on to our next speaker, Dr. Subhashini.
Yes, ma'am. Good evening, everyone. I actually feel very privileged to be part of this program. Thanks, Dr. Chitra and Dr. Muralidhar. Just to recap the case, it's a 45-year-old patient with PACG, 270-degree angle closed after YAG-PI, not tolerating drops, IOP 25, moderate glaucomatous damage, vision 6/9 with early cataract, and fellow eye is well controlled. There's no doubt that we have to do a surgery, but the big question is whether to do a TRAB or a combined. So TRAB with MMC would be my surgery of choice, as the IOP is high with intolerance to medications. Why only TRAB? So that's our main goal here is control of IOP. And the cataract is not visually significant. Vision is 6/9, and the patient is just 45 years old. And what is required at the moment is aggressive management of the glaucoma. There are advantages of doing only TRAB. We get a good IOP control, which is sustained. There's less risk of progression of the disc damage and visual fields, less inflammation because it's a single surgery, and so less chance of bleb failure. Why not combine? We all know that eyes with PACG are functionally and anatomically different from those encountered in routine cataract surgery. So this poses unique challenges in cataract surgery because of the shorter axial length, shallower AC, thicker and relatively anteriorly positioned lenses, whatever that Dr. George put forth. And generally, when do we consider a phacotrab? So the usual scenario is when the cataract is a primary indication for surgery. That is, an individual with glaucoma has a visually significant cataract requiring surgery. So we need to face reality. Here, the success of lens removal and angle closure, it depends on the extent of permanent or oppositional angle closure and the potential for reversibility. In our case, there is 270-degree closed angles. So lens extraction itself would not suffice to prevent progression of glaucoma, and it's not going to change the angle configuration or the course of the disease. That's not going to work in this case. So the same literature which Dr. George showed, the surgical outcomes between phacotrab and trab, the IOP control is comparable. It's not that phacotrab is going to have extra pressure reduction. It's not at all. And there is poor IOP lowering efficacy in PACG patients with angle closed totally, almost closed, as in this case. And there are disadvantages of doing a combined. The incidence of complications are more. So Dr. George was always comparing phaco to trab, not the combined with trab. So we are not talking about phaco, we are talking about phacotrab. So they also do have complications just like trab, corneal edema, hyphema, shallow anterior chamber, increased IOP, and choroidal detachment. And the anterior chamber depth, if you see, it is much more following phacoemulsification than with the phacotrab. So with the phacotrab, you're not going to get a deepened AC, and this is not going to reduce the formation of PAS or improve the IOP as for this case scenario. So, and always there's a possibility of going for a cataract surgery at a later date. So it can be done sequentially. Here, the priority is IOP control. So we do the trab first. So after 6 months or later, when the cataract becomes visually significant, we can plan for a cataract surgery. With careful monitoring, with modern cataract surgery and clear corneal incisions, the incidence of bleb failure is going to be less. It is true that IOP can rise following a trab, following a cataract surgery in a previously done trap. And in fact, Chen et al. Identified few factors like iris manipulation, age less than 50, preoperative IOP more than 10, and cataract surgery, which is done within 6 months after trap. These are all risk factors for poor bleb function. And so actually, if you monitor these cases and consider these factors and postpone the surgery to much later time, if we just look for signs of bleb failure, we can increase the topical steroids or give more 5FU injections, we can save the bleb. So final thoughts, as such, the success of TRAB is lower in Asians than Caucasians. Why then do an additional surgery and reduce the success rate further? So by doing a phaco-TRAB, we are only increasing the chances of bleb failure in the near future, and patients have to be restarted on medications to which already the patient is intolerant. So we are back to square one, and it's not at all doing a combined in one sitting is not cost effective because it's going to fail earlier than a TRAB, and patient may require additional surgery like a GDD or even MIGS. So to conclude, let's keep it simple. So what I would say is go for a TRAB that later, if the cataract progresses, we can knock off the lens. Thank you.
Thank you. Thanks a lot, Dr. Subhashini. We go on to Dr. Pandav. His thoughts, final thoughts.
Thank you, Dr. Chitra. I think both George and Subhashini have presented their case well. I think they quoted relevant literature and, to support, their line of thinking. George, you mostly, talked about the cataract surgery versus trabeculectomy, and the combined surgery. You did quote, some literature, but that doesn't really support that one would be better than the other, because as Suhasini already said, also said that if you're combining trabeculectomy, phaco with trabeculectomy, the complications that are because of trabeculectomy, they do not go away. They will still be there. In addition, you have a phaco surgery, which can also have its own set of complications. So on complications front, probably we may not be that comfortable when you are combining cataract plus, glaucoma surgery in an angle closure in a case like this. But having said that, there's an advantage of removing the lens because that will deepen the anterior chamber, open up the angles, and the IOP control will be better. And also the visual rehabilitation will be quicker and faster, so the quality of life would be better. On the other hand, if you're doing trabeculectomy first, they're likely the cataract is going to progress because there's already a cataract there, so it's going to progress, and this patient would need another surgery in a short span of life. It will not be good for the bleb that we have created. So I think both of you have your points of view, but my approach would be a little different to this because, as Suhasini said in the end, keep it simple. So I would say there's a cataract, there's a uncontrolled IOP, but the angle is still half of, at least it's still kind of open, it's not cynically closed. So I would do a cataract, the phacoemulsification alone in this patient to begin with. So remove the lens, that will deepen the anterior chamber, open up the angles, and the chances are that the IOP will be controlled only with phacoemulsification. And even if it's not completely controlled, at least the requirement of the drugs will go down, and you might be able to meet target IOP with 1 or 2 drugs. And that is what I think the George actually supported, with a lot of literature, because he did suggest that doing phacoemulsification versus trabeculectomy in this patient might have an advantage over doing trabeculectomy, and on the same count doing a combined phaco and trab. So I would rather go sequentially, but in favor of cataract surgery first, and then reassess your IOP and whether you need another surgery or not. Doing surgery, doing trabeculectomy later on also has an advantage because you are doing one surgery at a time. So your surgery is less traumatic, much better planned. And if your eye is pseudophakic and then you are doing a glaucoma surgery, whether trab or some other surgery, you can actually plan it better and execute it better. So my approach would be to do it cataract surgery first in this case, and then see what happens. And we have, I think, good amount of experience in this, and we have published that in IGO also. And in fact, we saw that even in an advanced, so this is not an advanced case, this is like a moderate disease at best. So this is a good candidate for cataract surgery first, and also happens to have cataract. So if there's a clear lens, then we would have to think, whether we want to do it or we want to do trabeculectomy first. But in this scenario, my approach would be to do lens extraction first, cataract surgery, phacoemulsification, and then evaluate, see how it goes.
But Dr. Pandey, I have a point here. The pressures are high. The scenario is the pressures are 25.
It will come down. Yeah, it will come down.
But with just a phaco, would it come down? It would deepen the chamber, but
yes, it will come down.
The patient is intolerant to medications, so we can't.
That was the published literature suggests that it comes down. And even our own experience is the IOP actually comes down. You may need 1 or 2 drugs, but you could get to the, where you want it. In case it doesn't come, then you have options. You have other options, in fact, because it's a moderate disease. So not only trabeculectomy, you also have other options that are also there in this case.
So Vashni, we've started combining with the MIGS in all patients of cataract who have glaucoma, irrespective of the stage, because if it's advanced, we might get away with not requiring a trab, and if it's moderate, we get away very well with reducing medication. So if we are going in for cataract surgery in this day and age, it's a very easy thing to just probably do a bang along with it, even if you don't have a KDB. And that would be our approach these days to do that. Just a small comment.
Thank you.
Dr. Vijaya, yes, Dr. Shanta, would you think differently?
No, I think you presented that this patient had 270 degrees of synechial angle closure.
Yes, yes.
So I'm not sure whether a mix would be possible, but if the angle opens up the table and you're able to visualize the entire trabecular meshwork up to the scleral sperm, then perhaps you could try to combine it with the.
Now we've started using the needle to pull down the synechiae, see the trabecular meshwork, and then do it. And it's amazing in angle closure how well it works. And I think it's because it's a trabecular meshwork problem and the outflow is not as bad as a POAG. So surprisingly, if we manage a bang in angle closure, they work better than they would work in an advanced POAG. That's very limited.
You're doing the goniosynechial lysis.
Yes, doing that and then doing the MIGS. So pulling it out and then just ablating, whatever, taking out the meshwork.
I think another point which has not been discussed here, Dr. Chitra,
yes,
is that doing cataract surgery alone and then doing trabeculectomy, you can do it within 1 month, 2 months time very easily. Whereas in case you want to do trabeculectomy first and doing cataract later on, then you need to wait for at least 1 year, if not more. 6 months, I think, is too short a time.
Yeah. Yes. We go on to our next session because I think there are many thoughts which have been put across beautifully. So we should know how to use our individual judgment now. So we go on to our next group, which is neovascular glaucoma. And here we have our presenters, Dr. Rajul Parikh. Dr. Roni George, if Dr. Rajul has not joined in, you would have to play his video from your end. You are aware of that?
Yes.
Yes.
Yeah, I'm aware of that.
Yeah. So we have Dr. Parikh, who's a glaucomatologist from the Complete Eye Hospital in Mumbai, and he's going to be saying that he would bet on trabs. And we have Dr. Neetu Mohan following in, who's a senior glaucoma consultant from Aravind Eye Care Hospital, Chennai, where she would chip in that GDD would be the way to go. And we have Dr. Tanuj Dada here, who's again, we know, is a head professor of ophthalmology from RP Center, a very eminent glaucomatologist who's going to be mentoring this session. So on to you, Dr. Roni George, to play Dr. Parikh's video, because I think he's caught up in an emergency surgery.
Madam, the case has not been read.
Yeah, yes, sorry. Murli, could you read the case?
Yeah, there is a 50-year-old one-eyed patient with old central retinal venous occlusion and neovascular glaucoma, which has now regressed with panretinal photocoagulation and intravitreal anti-VEGF. The angles are closed. The vision is 624 because of cystoid macular edema, and he has undergone intravitreal Avastin and Tricot, multiple injections. The left eye I mean, he's a one-eye patient, now has a Tmax of 40 millimeters mercury on maximum medical therapy. So over to you, Dr. Rajul.
You have to increase the volume.
Audio we can't hear.
Dr. Roni,
This is better?
yeah. We can hear you. You're not able to hear him, no?
Yeah, I'm increasing the audio to maximum.
Yeah.
Is opening the glaucoma data. We have a long follow-up data.
Okay, fine.
In few publications data, that even at the end of 10, 15 years, we can have a trabeculectomy success more than 50-60%. So, 60% to 65% of patients can be well managed, well controlled, only with the trabeculectomy. Yet, the two publications have just given again for opening the glaucoma, and I'll be talking about it a little later. Publication of Barwit and Ahmedwal. So we don't have Barwit, but we are using Ali. So which is based on the similar principle of non-Barwit mechanism. And if you look, even a 2 years data, the success rate at best is around 75%. And we know in any surgery, glaucoma surgery, the success reduces as the years goes by. So the long-term data, and if you look 5 years data of with Barwit comparisons, again, the success rate is definitely much less in trabeculectomy. Again, I'm talking about opening the glaucoma. Then the tubes have their own problems. Hypertensive phase is more common with MS, more commonly used in each scenario. And of course, the starting of hypertensive medication in first 2 weeks reduces the risk of hypertensive phase, but it is there, and even the patients are high, you don't want hypertensive phase. Then the corneal complications like decompensation. Studies have shown that corneal decompensation is high after glaucoma treatment disease. The malposition, it leads to the corneal decompensation, corneal edema. Migration, anterior migration as well as posterior reflections, which goes from the anterior chamber in those situations is not ideal. In a tube blockage, because of the iris, papular, the membrane, vitreous, this is because of the vitreous, silicon oil. So the tube blockage will lead to the again high IOP. In your exclusion, you can see the tube is excluded here. This is the Ahmed valve with the past on a clip. The whole clip is exposed. In a barbed, the valve has been migrated and extruded outside. So these all complications which are primarily related to the tubes or valve, whatever we implant certain glaucoma devices. We don't want this. So for opening a glaucoma, like with the remains that we started procedure treated. We have lots of publications confirming this. Now, I will come to the universal glaucoma. Now, I have just given the few publications. The success rate of trabeculectomy with mitomycin varies 60 to 80%. At 1 year, it reduces to 50% at 5 years. So then we the success rate of surgery is less. But with the wide use of the intravitreal anti-VEGF injections and ERP, the preoperative use of anti-VEGF has increased the success rate of trabeculectomy significantly. So we are using anti-VEGF injections and trabeculectomy with mitomycin. The success rate is very high. The only risk factor, most common risk factor, is young age and history of previous treatment. So in those cases, trabeculectomy success rate is less. Otherwise, trabeculectomy with mitomycin, even in NVG, is very high success rate. And there are some publications for this. Now, the drainage devices
So that is the other alternative we have. We are not talking about cryo. When we seeing a we can do not consider destructive procedures. Now, if you compare the success rate of drainage devices in NVG, of course, is much less than other indications. So the success rate in NVG is less, whichever the technique we use. The studies have shown that the higher use of BRP or individual therapy does not increase the success rate of AGV, which happens with the traffic light. And studies have also shown that the IOP reduction between Ahmed and Barbell, so ADI, by extrapolation is more or less similar. If you look Ahmed versus Barbell study, the final results, the multivariate analysis when the NVG was in place, the success rate was more or less similar. There are some quite a few complications with it. The interest is TEF versus drainage. So when you compare, in Chinatal have published 2 years later, trabeclectomy 55, Ahmed glaucoma 16%. The prospective studies have shown that the use of anti-VEGF before trabeclectomy increases the success rate in TRAB, but the same thing doesn't happen in Ahmed glaucoma. So in qualified success rate was more or less similar. In fact, was higher in trabeclectomy. The Wang et al. On contrary reported AGV having higher success rate than trabeclectomy. But the absolute success probability was more or less similar at the end of 1 year, 71% in AGV, 50%, but statistical significance was not achieved. We can say that AGV was little better than trabeclectomy. So various studies have shown different results, but no conclusive evidence that one is always better than the other. To conclude, the various studies have shown similar success rate in trabeclectomy compared to glaucoma drainage device. Trabeclectomy is surgery. I will not talk about glaucoma specialists, but the general observation is more often than the drainage devices, the cost involved. So overall, I think the various parameters, I would say trabeclectomy is the first choice of surgery. Even in NVG and drainage devices could be kept as a second choice if and when needed. Thank you.
Thank you. Thank you, Dr. George, for helping out. We go on to our next speaker, Dr. Neetu Mohan.
Good evening. Is my screen visible?
Yeah.
So thank you, Dr. Chitra and Dr. Murli, for letting me be a part of this. So I'll be talking on vascular glaucoma. Glaucoma release device would be the way to go for this case. So the case summary has already been mentioned. I will not repeat that. So as we know, in neovascular glaucoma, once the primary cause is addressed by a PRP and intravenous anti-VEGF injections, we have a choice between trabeclectomy and a glaucoma drainage device. And what is the rationale for a tube in these size is what we'll be going to. So many of these studies sir has already discussed. So basically, these are the larger studies comparing tubes and trabs in neovascular glaucoma, and they report similar success rates, albeit with lesser complications in trabeclectomy. But what is important is that the technique is not the same in all these studies. There are inferior tubes, many are tubes without patch grafts, express shunts have been included. So this is a meta-analysis which compared all the modalities of treatment for neovascular glaucoma, an AGV versus an AGV with an intravit injection, diode CPC, cyclocryotherapy, TRAB MMC, and TRAB MMC with an intravit injection. And they concluded that out of 1,303 patients, when the data was analyzed, they concluded AGV with an intravit injection and diode CPC were most effective in IOP reduction and had better success rates when compared to all other interventions. And the data of each adverse event was insufficient, so the safety of the 6 treatments could not be evaluated with the data that was available. So as you can see, AGV with an intravit injection is superior to a TRAB with intravit as well as an AGV, which are similar in outcomes. So do all trabeclectomies do well? Looking at the causes for failure of trabeclectomies, one of the most important, which is pertinent in our case, is the age of the patient. The probability of success at 1 year in patients less than 50 years was 35.6% in the study when compared to 72.2% in patients above 50 years of age. because of the more vigorous wound healing response and the earlier onset of NVG, reflecting on the fact that there's a more severe ocular and systemic condition which is present in the patient. Unremoved proliferative membrane or an unrepaired retinal detachment and a fellow eye with NVG caused by a diabetic retinopathy are also risk factors for failure, but that doesn't directly apply to the scenario here. Previous intraocular surgery, patients with previous vitrectomy did much worse when they underwent trabeculectomy when compared with patients who did not undergo previous vitrectomy due to the diffusion of vasoformative factors and the inflammation caused by vitrectomy. What about combined surgeries? In combined surgeries, when an AGV and a trabeculectomy were compared, AGV did much superior to a trabeculectomy. They needed fewer anti-glaucoma medications, mean IOP is significantly lower, and the surgical success at the end of 12 months was superior when compared to a trabeculectomy. And many of these patients with neovascular glaucoma, even after glaucoma surgery, demonstrate recurrent IOP elevations, rubiosis, diabetic macular edema, as in this case, vitreous hemorrhage, tractional retinal detachments, since there is an ongoing systemic pathology there. As in this case, this patient of ours is a 36-year-old female patient with Eads disease who underwent a tube in 2018. Since then, she's undergone a retina surgery, an oil removal, phaco, multiple intravit injections, and except when the time when there is an active bleeding in the eye, IOP has continued to be controlled on medical management. And this is the most relevant point for this case which we are discussing today, which is the IOP being uncontrolled on maximum medications and after an intravit injection. A 23-gauge entry and a valve glaucoma drainage device would, in my hands, I feel would be much safer than a trabeculectomy, even in the presence of a pre-placed suture and post-IV mannitol. This would be more controlled than a trabeculectomy. So as of all the complications reported on table in a tube, expulsive hemorrhage and suprachoroidal hemorrhages are extremely rare on table with tubes when compared to a trabeculectomy in an uncontrolled intraocular pressure scenario. So young patients, earlier surgeries, uncontrolled intraocular pressure, presence of tractional retinal detachment, and combining with other surgeries are the scenarios where a glaucoma drainage device would be preferable over a trap. And in this case, 50-year-old and IOP 40 millimeters of mercury on maximum medical management post-injection these are the two red flags which would make me favor a tube rather than a trap in this patient. Thank you.
On to you, Dr. Tanush.
So thank you, Dr. Chitra, for this kind invitation. And I congratulate Dr. Neetu Mohan and Rajul for very excellent presentations. So my take on this scenario is, I think the most important thing to understand is whether the eye is inflamed or no. So if your retinal colleague has done adequate laser, there is no fresh angiogenesis, neovascularization has regressed, and it's a quiet eye, then I would start the patient on preoperative steroids, topical, and proceed with a trabeculectomy, keeping in mind one more important factor that was not clear. The patient is phakic. So it's a 50-year-old phakic patient. So in that scenario, if it's a quiet eye, a trabeculectomy would be give a good outcome with preoperative steroids, and it will also protect the corneal endothelium. That is very important because it's a young patient. Secondly, if the patient is pseudo-phakic and if the inflammation is not controlled, there is some amount of NVI is present. In that scenario, a tube would be better, and that would be a tube in the ciliary sulcus. So for this particular one-eyed patient who's phakic, I would prefer first scenario to be a trabeculectomy with mitomycin C, adequate steroid cover after ensuring that there is no new vessel in the anterior segment or the posterior segment. And then later on, you will have to give aggressive postoperative therapy so that there is no inflammation. If this tube fails and you have done your needling, then I think next stage would be doing a tube, and that will also entail removing the lens and then doing a tube, because that would be the safer option. Another intermediate option would be that if the patient has got a cataractous lens, you have given your anti-VEGF and done adequate laser, then first stage, you can take out the lens if there is a cataract and combine it with the endoscopic cyclophotocoagulation. So that will give you some time when pressure is controlled, and subsequently you can plan for a trabeculectomy or a tube. So that would be my options for managing this case. Thank you.
Thank you, Dr. Tanuj. There's one question. Like in a neovascular glaucoma, if the NVI has regressed, there's retinal ischemia is well controlled, would the first tube has failed for different reasons, not this particular case, in general. Would you consider doing a trab as a second choice, or it's only a second tube?
No, madam. Once you have put in a tube and the conjunctiva has already been manipulated, then doing a subsequent tube has very high chance of failure, and you will get a shallowing of the anterior chamber, and your tube will also damage the endothelium. So I think once a tube is in, the second choice is either a cyclodestructive procedure or a second tube. I would not prefer to do a trab. Other way around, it's fine.
Right. Anything to ask Murli before we go on to our next session? It was a wonderful discussion by you, Dr. Tanuj. You put it all so clearly.
Sir, do you still use micropulse lasers, sir? Micropulse transcleral photocoagulation.
So micropulse is used when other surgeons refer some VIP where they don't want to do surgery, elderly patient, 80, 90 year. So then we do micropulse. So it works for maybe 6 months. So it's just a transit intermediate procedure. You have to repeat it. So currently, because we have doing it free, so people are referring to us, but I don't think it is a long-term modality for IOP reduction. Interim, it can work. For few months, it can control the IOP, but not as a procedure to have a definite control of IOP.
Thank you. Thank you, Dr. Tanuj. Thanks a lot.
Thank you.
We go on to our next session, which is silicone oil-induced glaucoma. And in this, we have Dr. Swati Upadhyay, who's a senior medical consultant glaucoma services from Arvind Eye Hospital, Pondicherry, where she's going to be talking on, I would bet big on MIGS. Dr. Siddharth Dikshit, who's a glaucomatologist from LB Prasad, Hyderabad, he's going to talk on, I would consider glaucoma drainage device as the first choice. And in this, we have Dr. Shushmita Kaushik as the mentor. And the scenario is a 20-year-old who has underwent pars plana vitrectomy with silicone oil injection and repair of the RD 6 months back. The IOP was 24 to 30 millimeter mercury from the first month onwards and has been on anti-glaucoma medication. The silicone oil removal has been done a month back for emulsification. And the patient now has on max treatment 28 millimeter mercury with 4 anti-glaucoma medication, inferior node, superior aqueous scotoma, high myope, vision of 6/6. So on to you. We have our speakers to chip in now. Dr. Swati.
Thank you, ma'am. Thank you for inviting me for this beautiful session that you have planned, as always. So I'll be, is my screen visible?
Yeah.
And am I audible?
Yes.
Okay. So I would bet big on MIGS for a silicone and oil-induced glaucoma. And my screen is. Yeah, so the scenario as told by madam, he's a young boy, he or she is a young patient, 20 years old. So why we use silicone is it's an endotamponate agent used with PPV, and it is established for 4 decades for now. And it's an agent of choice in complex cases of RD, PDR, trauma, viral retinitis, giant retinal tears, macular hole repair. But in spite of its obvious advantages, increased IOP is the second most common complications after cataract, with the prevalence of 2.2 to 56. So silicone oil makes retina people happy, but the glaucoma surgeon cries later on. So what are the mechanisms of glaucoma in silicone oil induced because of silicone oil? It can be early because of pupillary block or inflammation or migration of the emulsified silicone oil or the silicone as such into the anterior chamber. In late mechanism can be infiltration of trabecular meshwork with silicone oil globules or globules, synic angle closure, rubiosus iridic, NVG, idiopathic, or migration of emulsified oil into the anterior chamber. Why is it difficult to manage these eyes? Because IOP may be difficult to measure in the first place because of an altered corneal status. Like some cases like these. correct evaluation of the optic nerve is also always not possible because of poor fixation, because of vitreous, concurrent vitreous hemorrhage, and the patient might have retinas or the media like this. So you cannot easily assess the optic nerve also. And when you are not able to assess the optic nerve properly, just going for a GDD doesn't make any sense. So there are options like laser therapies, SLT, TRAB with MMC, GDDs, and MIGS. So why mix? I'll come to it. But what are the options we have in mix now in India are suture guard, KDB, goniotomy, micropulse laser, Hydrus, which is not yet available, but will soon be available in India. Zen, which is also not available in India. So in India, we have suture guard, we have ECP, we have KDB glide. So why mix? Because there is an ability to cannulate and cleave the trabecular meshwork without violating the conjunctiva. The conjunctiva is preserved for future bleb forming procedures, and it can be performed in significantly conjunctival scarring, status post-scleral buckling, and vitrectomy. And it avoids major complications like hypotony, corneal decompensation, and which is seen in tubes and trabeculectomies. And it doesn't sacrifice IOP lowering efficacy. And then you are left with a healthy cornea in the end. So why not GDD? GDD offers a good surgical option in cases, but you have tube-related endophthalmitis, corneal decompensation, then you have the silicone oil going into the tube and obliterating it or occluding it, and then we have hypotonic maculopathy. Also, there is a possibility of silicone oil escaping via the glaucoma drainage tube, and this is a study done by Sen et al. Where they have found that the silicone oil was resting, and there was in the inner surface of the bleb, as well as the intracellular and extracellular deposits of silicone oil were found in the wall of the bleb. So why not GDD in a 20 years old patient? Because the life expectancy which we are seeing is another 60 years, and exhausting the last option at the very beginning is not justified. And he's a myope, he or she's a myope. Thin sclera is expected, and future need to do scleral buckling can also be there. So if you place a very broad base GDD, which we have RD here in India, so we are compromising, we are just exhausting the retinal option also for the future. The patient has 6/6 vision. What if hypotony happens and we need to take the patient again for tube religation or supramid suture stenting? And then tube-related complications, which Dr. Rajul has also said, which so many speakers earlier to me have already said, that tube extrusion, tube migration, and so many others, and damage to endothelium, which Tanod sir is also saying that damage to endothelium is irreparable. Then you have to think of PKP, and then the thing gets complicated step by step. So currently, what are the MIGs which are being tried and with success in silicone oil are GAT, as Dr. Davinder has told, outcomes of gonioscopy-assisted transluminal trabeculotomy in vitrectomized eyes with secondary glaucoma after silicone oil removal, a study done by ACTAS. They have shown that GAT seems to be safe and successful procedure. Another study by Ann et al. They have also showed that in secondary open angle glaucoma following VR surgery, and GAT is a safe procedure. What about an inferior Zen gel stent? My GDD colleagues will say that, okay, why we are not going to place a tube in the superior temporal quadrant, we can place it in the inferior nasal quadrant. Then we also have inferior Zen gel stent, but the problem, it is first not approved in India. And this is a study done by Savastino et al. And they have shown that in refractory glaucoma, in vitrectomized eyes with previous oil taponade, the inferior placement of Zen 63 gel stent delivered an adequate intraocular pressure reduction at 6 months follow-up. What about ECP? Dr. Vanita has done a lot of study, she has a lot of cases on where she says that ECP is a very good option. And this is a study done by Lima et al. This is a prospective study, and where they have shown there is no difference in the success rate between AGV and an ECP in refractory glaucoma. Another study shows that ECP for refractory glaucoma has a success rate, and it causes 34% reduction from the baseline. Another study by Yoko Murakami et al. Have shown that both ECP and GDD2, this is a second GDD, significantly lowered IOP and the number of anti-glaucoma medication. Another what I would like to say, this is not a mixed procedure, but Expression Mini has also been studied in silicone oil-induced glaucoma, and it shows that the complete success was achieved in 73% of the eyes and qualified success in 81.8% of the eyes. Another study done by El Saida et al. They have shown that success rate of 100% with Express Minition. Also, pars plana, we can also prove pars plana express minition for management of persistent glaucoma. And this is even after oil removal, they have tried. What about SLT? SLT is available in many parts of many centers now in India, but unfortunately, it's not available to us in Pondicherry. But still, SLT, as Davinder also said, that it also has a role. It has SLT is safe and effective option for treatment of patients with silicone oil-induced secondary glaucoma, and also a study done by Alkin et al. Have shown that SLT may be successful for lowering IOP in POAD secondary to silicone oil. But what about iStent and iStent inject? First of all, they are too costly, and there is no studies to substantiate their efficacy in this group of glaucoma. And chances of stent getting occluded or clogged with silicone oil globules is also there. So to put a 1.5 lakh in iStent inject in a patient who is 20 years old, when we know that silicone oil might go and obliterate the 1 millimeter lumen, it's not justified. So I would like to conclude that managing medically resistant IOP elevation status post PPV with SOR is a challenge. Trabeculectomy and GGD have lower efficiency and high complication rates in such situations. So mix in the form of GAT, inferior Zen, or KDB goniotomy should be considered as the first option. But the treatment options should be directed at the underlying mechanism of secondary glaucoma for each patient, balancing the risk of intervention with the expected benefit. So in the end, I would like to say using the right tool for the right job makes all the difference, but knowing which tool only comes with experience, and MIGS is the right tool for the eyes with silicone oil-induced glaucoma. Thank you.
Thank you, Dr. Swati. That was a wonderful presentation. On to you, Dr. Siddharth. You have a tough path to take.
Thank you, Dr. Chitra, for having me here in this plethora of stars in the glaucoma world in India. It is also, though, funny because everywhere I go, I keep defending GAT, that I am speaking against GAT. And it was a wonderful presentation, Dr. Swati. But I have my weapons to throw at you. I will just skip the summary for now and look at why silicone oil-induced glaucoma is a challenge. And despite having multiple options available to us, we are still confused and are debating about which of these can be performed. And this probably is the only glaucoma where the gold standard does not work. And everybody agrees on that. And we are looking at the two spectrums of MIGS and GDDs to do the surgery for. And it does not work because any conjunctival filtration, even if you use a Zen implant, and somehow if the silicone oil enters the conjunctiva or has been in contact with conjunctiva, and which can also escape through the 26 or 27 gauge vitrectomy ports, it induces massive inflammation, which will lead to fibrosis of anything, any tissue that comes in touch with the conjunctiva. And an example of this is this study which compared AGV with express trab. And it found, it is a very small study, it's not a big study, but it found that the success of AGV in these patients was much more significant than in patients with express implant over a period of 12 months of follow-up. Let us look at what GDDs or in fact AGV has done in patients with silicone oil-induced glaucoma, or SOG, as I like to call it. So this group from Ike Ahmed and Peter Netland, they published a literature and saw and compared two groups, the orange one, which has silicone oil, which does not have silicone oil in situ, versus those who had silicone oil endotamponade, and found a significant difference between the two groups, which basically means that AGV does not do as well in silicone oil-induced glaucomas compared to those otherwise. Similar experience, but slightly better or slightly worse, was seen in different studies that are published on AGV in SOG. Now, whether we should do an AGV or ADI if we are proceeding with an implant, the answer should come from the Ahmed versus Bavelt study. So we know that Bavelt does better as far as overall success rate is concerned, gives you lower intraocular pressure, lesser intraocular medications, but it also gives you more complications related to hypotony. And a lot more patients are likely to lose vision when you do a non-valve implant. this I will extend to other non-valid implants which are available here, like the clear path, which basically means that in a high myope, a patient who has had an RD surgery, I would like to do AGV rather than these non-valid implants. Where does TACPC stand? You look at this study. This is a very interesting study. 17 eyes underwent implant, 39 eyes under TACPC, and it was seen, as we all almost would intuitively agree, that the effect of TACPC was transitory. And 53% of the eyes, after initial good control, lost control over time. But what you see here, amazingly, is a 94% success rate of AGV in these eyes. And that is because these surgeons have made sure that an SOR was performed for these eyes before the implant. And even if this fails over time, it's improper to actually project on what happens in the future. But this is a very promising data of 94.1% success rate for implants. Now, what are the additional factors that will help me decide on whether you have silicone oil under the conch or not? And if it is there, where is it located? Do I go superotemporal, inferotemporal? Inferotemporal is preferable, but if you have silicone oil particles, that gets ruled out. Also, very importantly, not all silicone oil induced glaucomas will have equivalent amounts of silicone oil in the angle. And even when one does a really good SOR, it is likely that some particles of silicone oil will remain in the eye. Now we'll come to something very important, and that is why I would say that I would never do a GAT or a Schlem's canal based mix in patients with silicone oil induced glaucoma. It has been shown that silicone oil, even from breast implants, can cause a lot of symptoms which have been related to autoimmunity. And if this you think is something that is kind of psychological game that people might feel, it has been shown in patients with implants that there were antibodies present against the silicone oil when compared to controls of to a level of more than 20 times. So silicone oil is immunogenic. Also, I'll give you an example of this patient where a vascular occlusion happened.
1 minute left, doctor.
Sure. Because there was fat injection given near the eye, and this led to occlusion. Now, the ophthalmologist, I don't know what he did to the cosmetologist, but imagine silicone oil going from the Schlem's canal to the episcleral veins to the systemic circulation, and the patient having a stroke. Can you ever prove that it was not your silicone oil that caused it? And even if it is causing something subclinical or not to that extent, can we ever be sure that it is not causing it? So at the end, there are multiple things, but we have to be patient. So in this patient, high myope 20-year-old, you would not want to go and do an implant. But given the fact that the patient is on multiple medications, seems to be possibly an advanced glaucoma, has had a vitreoretinal surgery, and because I love my neck, I will either go ahead with an implant or as a temporarizing measure with a TACPC. Thank you, and I rest my case.
Hello, thank you very much. I think both have made their case quite convincingly and have presented their data. But as for all glaucomas, I think it's not one basket possibly. And there are a few things to consider when you have a patient in front of you. For instance, the most important thing here was, is he phakic or not? So that would take ECP, I think, out of the gamut if it's a young boy who is phakic. And I would also be a little concerned with putting in a glaucoma drainage device in a phakic young boy with 6/6 vision. And I think the more gray hair you have, the further away from devices you go, simply because you see those patients much longer. So in that sense, I would say Swati has a point in thinking that with 24 to 30 millimeters without diamox, maybe minimally invasive would have a point. But then on the other hand, I would be very concerned with fibrosis within the outflow channels. And I'm not sure that having emulsified oil in the angle would take away the possibility that there would be fibrosis in the outflow channels. And if you take this person up for surgery with whatever attendant risks and land up with more harm than good, that's something to be taken. So I think an informed decision and an informed judgment would be important in all. But if you ask me personally, 6 months later, 24 millimeters, young boy, I would probably, as Siddharth said in the last line, give it one small chance of a limited TSCPC with transillumination. Believe me, nothing happens with 180 degrees. And if you transilluminate and you know exactly where the ciliary body is, especially for post-vitrectomy surgery, it is probably the safest and the least invasive thing so far. So that would be my take. But then each patient, as Swati's last line said, has to be taken as what the patient has and what you can do for him the best. Thanks.
Thanks, Dr. Shushmita. Murli, you have anything to ask before we go on to the last session? But the things have been very well discussed.
I mean, is there a quadrant preference? I mean, would you say that inferior quadrants for silicone oil induced glaucoma for a GDD implantation?
Yes, absolutely. Always. Inferonasal is my preference. As much as fibrosis can fail a trabeculectomy bleb, that much of fibrosis can fail a GDD bleb as well. So yes, we assume inferior PIs. That's another thing to be very, very careful about, that there is an inferior PI. And if you're putting in a GDD, at least my preference is an inferonasal quadrant first. Of course, the other thing you need to keep in mind post-RD is where the band and the buckle is, because then you need to plan your surgery according to that as well. That's the other thing to remember.
Thank you. Thank you very much. We go on to the last group of post-K-Pro glaucoma. And we have Dr. Sirisha Sendil, who heads the glaucoma services at LV Prasad, Hyderabad. And she's going to say, I would consider GDD as the first choice in this very challenging scenario. And Dr. Mulli Arigav, who heads the Sundaram Medical Eye Foundation Department of Glaucoma, and he would talk on, I would hang on with the lasers. And mentoring them would be Dr. Davinder Grover. Murli, after you read the case summary, I would, I guess Dr. Grover has already joined in. Thank you, Dr. Grover. Murli, can you read the case summary?
Yes, madam. So we have a 20-year-old who has underwent, I'm sorry, one second. Yeah, we have a 45-year-old with keratoprosthesis. I forgot to add it's a type 1 keratoprosthesis after mucous membrane grafting in ocular cicatricial pemphigoid. The globe is digitally hard on maximum medical therapy. Vision is 6/9. And the left eye also has severe ocular surface disease and is projection of rays inaccurate. So we have a one-eyed patient with type 1 K-Pro and a mucous membrane graft in place for ocular cicatricial pemphigoid planned for surgical management.
On to you, Dr. Sirisha.
Yeah.
Thanks for being with us.
Yeah, I hope my slides are visible. So for that case scenario, let me come towards the end. But before that, I think we need to understand that keratoprosthesis and glaucoma is not an easy situation. So I thought I'll just give a brief about what the keratoprosthesis is and why is it that we are so concerned about managing glaucoma in these patients. All of us will agree that these eyes cannot be managed with multiple keratoplasties and they continue to fail. Keratoprosthesis definitely has a role to play. But what is very important is the retention rates were very poor in the earlier days. And with the better equipment and with the better design of the devices, the retention rates are far better. But what is also very important is what it is in India. We know that in our series that we have presented, close to about 70% is the retention rates. Why is this important? Because the longer the retention of the keratoprosthesis, we are going to have the problem of glaucoma. So there's a higher incidence of glaucoma. The pre-existing glaucoma is high. Post-surgery, the glaucoma is also going to be very high. And these eyes, multiple interventions are required in these eyes to control the intraocular pressure. In our scenario, we have seen close to about 30% of them required glaucoma surgery, which is far less compared to what we see in other situations. So I'll give you an example of this patient who's had very severe ocular surface injury along with the loss of cornea following a cracker injury. So there was a chemical injury, there was mechanical and thermal injury. It's a combination of everything. This boy underwent multiple surgeries before he underwent a keratoprosthesis about almost 5 years after the first intervention was done. His fields were quite fine after the surgery. And then, within the next 10 months, he developed a very advanced glaucoma. So the challenge in these patients is that IOP estimation as well as what happens in the angle is something that we cannot evaluate. Many times desk evaluation is possible, but sometimes with the difficulty in evaluation because of the retroprosthetic membranes and things like that, that makes this also very difficult. Visual field evaluation definitely has a role to play, but then again, if the vision is not so good, then that also becomes very difficult. Now, we are left with managing these patients with finger tension, elevated intraocular pressure, just like what Murali had mentioned, digitally hard digitally hard eye. So digitally hard means what? Is it 30? Is it 40? Is it beyond that? We have absolutely no idea. So I think what we need to definitely understand in these patients is evaluate ultimately, this is what we have to treat, evaluate the intraocular pressure in a better way. Digital IOP estimation is important. But these eyes, if the conjunctiva and the sclera is all right, and the cornea, of course, has prosthetic cornea, Sheard tonometer is definitely useful in recording intraocular pressure in these patients. And compared to all the other tonometers that are available today in the market, scleral Sheard's intraocular pressure had the least error compared to anything else that we have. And also we have developed a nomogram, which will help us to actually estimate the intraocular pressure, the GAT intraocular pressure by a scleral, the Sheard tonometry IOP that we record. And we've also shown that compared to the digital intraocular pressure by an expert, the predictive model actually gave a good agreement with a kappa of 0.8 and accuracy of 91%. So based on all these findings, we at our institute actually use both the digital intraocular pressure and the scleral Sheard's IOP to monitor the intraocular pressure in patients with keratoprosthesis. Fine, you have recorded the intraocular pressure, pressures are high. How do we handle them? Topical medications can be used, but they possibly have limited efficacy. And most often these patients, just the topical medications are not sufficient. They will require either oral medications or either a GDD or an endocyclophotocoagulation or the transscleral cyclophotocoagulation based on the surface and based on the intraocular pressure and based on the visual potential. So the typical scenario that you described is the ocular cicatricial pemphigoid with a patient with keratoprosthesis. So in patients with OCP, they have difficult conjunctiva, they have scarred conjunctiva, and these eyes are more fibrotic as well. So GDDs definitely have a role to play, but yes, what we need to understand in these patients is that in a situation like this, per-operative and post-operative oral steroids are very, very important. And I would, in a situation like this, definitely put in a valve device, because non-valve, we do not know, hypotony is not something these eyes can actually tolerate. But if the conjunctiva is terribly scarred, I don't think we have an ego here. If the conjunctiva is terribly scarred and you don't have adequate tissue to be able to place a GDD, don't even worry about it. Go ahead and do either a transscleral or an endocyclophotocoagulation. So in situations other than the situation that was described now, but if you have a very hazy cornea and if there's and the pressures are elevated, we would obviously go in for a combined implant as well as a keratoprosthesis. That will take care of both the problems together. But in situations where you have this was a patient who had terribly scarred conjunctiva with symblepharon, we can place a GDD, but you have to be extremely careful in trying to close the conjunctiva in a very meticulous way. Post-operative complications with implants are not unknown, so we have to be very, very careful with these eyes. Unnecessarily placing a device just because prophylactically somebody has to go and do it because they have a higher tendency to develop a glaucoma is not something that we agree. And we always have to remember that retroprosthetic membrane as well as blockade of the tube at a later time point with vitreous is not uncommon in these patients. So all that has to be taken care of before we actually place these implants, except for one study, this study where they have actually not seen too many complications with GDTs over a long time. Many of the situations end up having complications. So one needs to be really, really careful. This is our data where we have seen as well. Conjunctiva related complications, one has to be really careful about, apart from the tube related problems inside the eye. So to summarize, I would say that these are difficult eyes to handle. The chances of glaucoma are very high. However, GDTs definitely have a role to play. That too, a valve device has a role to play in taking care of these patients. And they need to be monitored post-operatively because implant-related complications, whether it is the tube inside the eye or the plate outside, are definitely high. And hence, we have to monitor these patients. And when we think that the devices, the implant devices are going to be unsafe, it's better to pass on and maybe end up, try and take help of a laser to be controlling the intraocular pressures.
Thank you so much, Dr. Srisha. That was a very complex situation you tried to simplify. We go on to our next speaker, Dr. Murli.
Yeah, thank you for the invitation. And I think my talk is sort of made easier with the very clear presentation made by Sirisha. And I entirely agree with her that these are difficult problems, eyes with difficult glaucoma to deal with. And we don't have the ideal solution, and we have to think of various options. So I'm going to discuss just a brief overview of the K-Pro, which we see in our area, and then about the management of how we manage the K-Pro patients in our practice. I think the Boston K-Pro is one of the most widely used keratoprostheses, and indications include, I think most of us know this, multiple graft failure, Steven-Johnson, OCP, severe burns, alkali and acid, and of course, poor prognosis with the traditional PK. But the three most reported post-operative complications after the Boston K-Pro have been the RPM, the glaucoma, the raised intraocular pressure related problems, and the infectious endophthalmitis. So glaucoma is a major problem with the Boston K-Pro, especially if these K-Pros survive for long. The few points about glaucoma and K-Pro is that you will find that about a third of patients will continue to have raised IOP, and sometimes it is not picked up. The glaucoma seems to progress in patients with K-Pro for some reason more than any other glaucoma. Following K-Pro, there's a decreased ocular surface area, which therefore we'll find that the medications don't work, the topical medications. You would definitely need to consider either oral Diamox kind of medication, or you must go in for surgical procedures. The steroids are another big problem here, and you don't know whether the perioperative steroid which you're using can cause the glaucoma and or its progression. The implant itself, the K-Pro itself, can cause tissue disruption, and the procedure related to the implantation affects the scleral rigidity, which can cause biomechanical damage to the optic nerve. And this may sort of explain the glaucoma progression that occurs despite apparent IOP control. The risk factors after the Boston K-Pro type 1 implant, the pre-existing glaucoma is definitely a high risk for glaucoma development. Autoimmune diseases and especially ocular surface diseases, SJs, OCPs, alkali burns, and reports have been mentioned about the HSV infection being a high risk for glaucoma and so on. The post-PKP synechiae, secondary angle closure, adds to the difficulties of the glaucoma following the in these K-Pro eyes. How do you diagnose glaucoma? I think is very clearly mentioned. We also use the scleral shots and the digital palpation, and nothing else is possible. Perimetry wherever possible. ASOCT somewhat more practical than UBM. UBM is very difficult to do in these kind of eyes. And of course, the most simple and the practical option seems to be serial disc photos. Keep watching the optic disc, digitally palpating the intraocular pressure, and whenever possible, any other imaging is can be done. But keep monitoring for the glaucoma with these kind of methods. Trabeclectomy is unlikely to succeed. The valve glaucoma devices, as Sirisha mentioned, are likely to work if done with great meticulous care and all that. But cyclodestruction is definitely my way of dealing with these kind of problems. Either the limited 180-degree diode CPC or the micropulse transscleral, which we have extensive experience now for the last about several years. I have no experience with the endoscopic CPC, but there have been reports of its use in these kind of eyes. So post-K-Pro glaucoma, like in this situation, which has been described as a 45-year-old after the mucous membrane graft, OCP, and a very hard IOP and with maximal medication, we know that the medication is not going to work. And of course, the other eye is lost. So here we have a lot of problems with the GDD, which you could probably think of. The conjunctival scarring and the prior surgeries will obviously dictate where the GDD is going to be placed. The K-Pro would occupy most of the anterior chamber, and therefore you can't really put it into the anterior chamber. You should probably think of a vitrectomy, and if it is aphakic or something like that, you could probably put it in the pars plane. Definitely, you'll have vitreous occluding the tube if you keep it in these kind of situations. It is preferable to introduce the tube via the pars plane after vitrectomy. And also, mind you, the K-Pro patients may also need a large diameter contact lens, and this can actually worsen the tube exposure if there's a continuous touch between the lens and the contact lens and the conjunctiva. And multiple procedures with K-Pro patients, which they already had, and the conjunctival scarring is actually a challenge to close the tube and cover the tube when you're doing this glaucoma drainage devices, especially in eyes with OCP and so on. So these are examples of typical exposure following the glaucoma drainage device from the K-Pro. You can also see a picture of the king tube and the occluded tube with the ASOCT showing the block tube with the after the GDD. GDDs are a nightmare sometimes. You will find that after the GDD is done, you will find everything works well, but you have this huge encysted blebs and very difficult to manage whatever you do. Still, the pressure remains high, and it's a nightmare explaining to the patient after all whatever you've done, the pressure still remains high with these kind of blebs. The diode CPC pros and cons. The advantage of the diode CPC is that it can be used before, during, or after the K-Pro placement. There is no hardware involved. These procedures have no risk of, relatively almost no risk of endophthalmitis or device exposure. So this would be my way to consider treatment option. The cons, of course, are there with the diode CPC also. You cannot really titrate the intraocular pressure control in the location of the ciliary process unless you're doing transillumination and so on. If the limbus is not visible, so multiple treatments may become necessary. So don't do 360 at the first shot. Even though the IOP can be controlled, sometimes you can have severe iridocyclitis, hypotony, and even loss of vision and phthisis bulbae and so on. These are the cons with the diode CPC. We used to use the diode transscleral G probe. Been using this for many, many years. And in these kind of situations, this is one option in which I would do probably 180 degrees, evaluate the response, and then consider if you need to go further on this, even 270 degrees and so on later. But mind you must make a record of how much you have treated initially, and keep the problems of iridocyclitis and other hypotony and related problems in mind. But of course, now I have moved on to the new micropulse CPC. This is the one which uses the micropulse technology and a short repetitive bursts with a sweeping moment as shown, unlike the previous application of spots and all that. And the duty cycle is about 31.3% with an on and off time of 0.5 and 1.1 seconds. We have slightly keep changing parameters based on the eye, based on the age, and based on the location and all that. But there are variations in the technique which I'm not going to discuss today. So the TSCPC micropulse experience, our initial paper, which we published in 2021, included about 5 or 6 eyes with the 6 eyes, I think, with the K-Pro kind of. This is one example of a type 1 K-Pro in which we had done the micropulse. She's still doing well, continues to do well. She had a tarsography in the other eye. The tarsography was released to do the micropulse TSCP. She has done extremely well with the micropulse, and her IOP continues to maintain digitally palpable, apparently normal kind of IOP after about this now the 4th year after which the diode CPC was done, the micropulse was done. And I also use the micropulse in other situations like intolerant to medication, post the glaucoma drainage device kind of micropulse TSCPC. So TSCPC is definitely an option. And in this OCPI, I would probably first consider the TSCPC micropulse first, and then look at the GDD as the other option. So definitely not my first option is the GDD. Would I try a 360-degree micropulse? And if necessary, a second option could be a 180-degree standard TSCPC. And of course, I would not consider the valve first. And I think somebody has already mentioned this in the previous lectures, that the cure for a cure that was worse than the disease is what we should keep in mind. You're already having a difficult problem. You already put in something which is a challenge. You put in the K-Pro. On top of that, you want to put in a tube in an eye with a cicatricial pemphigoid and an ocular surface that has had a mucous membrane graft. So your treatment should not be worse than the disease itself. And mind you, we are here to treat patients, and we are not trying to have ego issues in managing intraocular pressure alone. So do no harm before you consider these kind of treatments in these patients. Thank you for your attention.
Thank you. Thank you, Dr. Murli, for putting across your points so beautifully. So yes, Dr. Grover, you have a difficult task to deal with both.
Yeah, I mean, both presentations were just phenomenal. So thank you both, Dr. Murali and Shrishra. They were just great presentations. These are sick eyes, you know, and there is not a right answer, and it's hard to generalize. You know, in the case example that was put forth with the OCP and presumed extensively scarred conjunctiva, sometimes a tube is not an option at all, right? And then sometimes what we'll do is we'll do I'm biased against valves implants. I don't like Ahmed valves. I don't think they work long term, and I think that they lead to longer, higher pressures. And I'm classically see those big capsules form, and so my bias is towards the non-valved implants, the 250 smaller implants. And I think that in these situations when there's limited conjunctiva, what you can sometimes do is what we call like a first stage tube, where you put the tube in, you don't connect it, you kind of put it off to the side, let the conjunctival heal, and then go in and later reintroduce the tube, so you've had some time to heal. So in those tough cases, sometimes you know, you can do a first stage small tube. I think without question, like both speakers have said, all these eyes, they need a, you know, they're going to be aphakic usually, and they need a vitrectomy, and they all get glaucoma. I mean, I think we got to assume that if they don't get it, they're going to get it. And because we don't have the ability to monitor it, I think we need to proactively address their pressure. Without question, you know, glaucoma it's the eye is like a drain in a faucet. It makes water and it drains water. If the drain gets clogged, I don't care if you have the faucet at, you know, the producing water at 100 degrees or 50 degrees, it's eventually going to overflow. Right. So if the drain is clogged, no matter how much diode you do, you're not going to get the pressure ideally controlled unless the eye starts going into ptysis. So I do think the preference, if it's possible, given the conjunctiva, is to put a tube shunt in the eye first, and make it pars plana, have a nice core vitrectomy. The key thing with these sick eyes, as you all know, is sometimes the sclera can be very thin. And when you go pars plana and you try to get it in there, if the sclera doesn't have the integrity, the tube can rotate anteriorly, and then it just gets clogged in the vitreous base, and you can't see it. So do your best to make it as long as possible so that you can always see it right in the center part of the keratoprosthesis, and so that it's not, and you can see if it gets clogged with vitreous. Hopefully you do a nice core vitrectomy. But again, if the conjunctiva is not healthy, you have no choice. Then the second option obviously is going to be a ciliary ablative procedure. The only other thing I would say is, you know, we have, I don't know if you guys have this available in India, but we have a pars plana adapter that basically gives the tube an angle. I'm not sure if you guys have access to that, but those are really nice in these situations when the sclera doesn't have the integrity to keep the tube at a perpendicular angle. But the only other thing, and I would love to hear more of Dr. Murali's perspective, but you know, I caution the use of micropulse. We were one of the first people to report on our outcomes with micropulse when it first came out, probably 8 years ago. And as Dr. Murali alluded to, every time you hear about micropulse, the settings are changing. You know, they're saying do 60-minute sweeps, do 90-minute sweeps, do 30-minute sweeps, do this pressure, do this lower, this power. And we're seeing, you know, I think a lot of what we do in glaucoma is voodoo. You know, we just don't know what we're doing, and as we don't understand why patients heal, and sometimes patients do well, sometimes they fail, and we don't know why they fail. But of all the things we do in glaucoma that we don't understand, I would put micropulse at the top of that list. When I do micropulse, I have a third of my patients do amazing. A third of my patients look like nothing was done at all. And a third of my patients look horrible. They have horrible hypotony, flare, inflammation, and it's so hard to predict. There are more and more cases in the US And in the US, we have I think a much more genetically diverse population because we have, so I think maybe in only Indian eyes, it's easier to titrate. But in the US, I can walk into a room and see someone who's of European descent. The next patient is going to be from Mexico. The next patient is going to be of African descent. The next patient will be of Chinese descent. Next patient will be of Indian descent. So it's hard to generalize. But in the US, we're seeing more and more people have complications from micropulse. And the vast majority of us have moved away from it and stopped using it because I feel it's so hard to predict. And I have a feeling actually it might get pulled off the market soon because I've seen a couple patients do really badly on it. So maybe in Indian eyes, where it's a little bit maybe perhaps more predictable, you guys are able to get some nice predictable results. But in my hands and a lot of my colleagues, we've moved away from micropulse and have gone back to more traditional CPC. And then, I love the comment what Dr. Melli made as far as, in these eyes, sometimes you don't know where the ciliary body processes are. So transillumination and all these things, you got to make sure you understand where the processes are before you treat it. But I think if you can get a tube in an eye with a keratoprosthesis, get a tube in the eye. And the only other thing I do as far as how I check pressure is, we do the digital palpation. I do a tonal pen, and I kind of will, in my chart, document where I do it. I do infranasal sclera on the tonal pen. And I'll use their healthy eye, if they have a healthy eye, as a comparison. So I'll do the central pressure and then do the infranasal scleral pressure, see if the central pressure is 20 and the infranasal is 40. And then this one, infranasal is 40. It gives me a sense that maybe the pressure is 20. So it's one more way to estimate what the pressure could be in the fellow eye, because it is so hard. But I think that while you can see hypotony in these eyes, I think the issue I'm more concerned about is glaucoma and the pressure being too high, not too low. So I would err on treatment, and I would err on doing a tube first if possible. But you guys take care of very, very sick eyes and have such a tremendous experience, and I'm so thankful that you're publishing on that to share with the world. And I would love to see more data on your experience with micropulse come out, because in the US we're having a really not good experience with it.
Thank you, Dr. Grover. Murli, do you have anything to ask before we conclude?
Yeah, I have two questions. One was your experience with either I know we do less of a type 2 keratoprosthesis or a osteoodonto keratoprosthesis, but would you recommend putting in a tube at the same time as we implant the osteoodonto keratoprosthesis or a type 2 keratoprosthesis? Because estimation of IOP is essentially not possible after.
Yeah. Ideally, it depends on the situation, right? If you can put a tube in first, and that would obviously, and then let the eye heal, that would be ideal, because then you'll know the tube is working. But that, if you're putting a tube in, the patient needs a vitrectomy, all right? Because the tube needs to be put in pars plana. So if the vision is good, or maybe you'll do just a regular PKP, knowing it's going to fail, so that you can do a core vitrectomy, put the tube in, let the eye heal, and then come back and do a K-Pro. I don't think there's a right answer here, but when you're doing a vitrectomy, a tube, and a K-Pro all at the same time, it's a lot for the eye to handle, especially these sick eyes. So if you can stage it, it's more ideal. But I would love to hear from Dr. Shreecha and Dr. Morales, see what they think.
Thanks, Devinder. I think that was a wonderful summation of managing these cases. So type 2 keratoprosthesis nowadays, the osteoodonto keratoprosthesis is done for those eyes where really they have a bony conjunctiva, where absolutely there's no conjunctiva at all. In situations like that, to go and place a tube is not going to be an easy thing. Unfortunately, these eyes with type 2 keratoprosthesis have less glaucoma compared to the type 1, because you're actually going and removing the cornea, the iris, the vitreous, and everything. They're just left behind with the shell on the outside, and then a keratoprosthesis in the front. So fortunately, they have less glaucoma, and we obviously cannot give topical medications in these patients. So they are on oral pills if at all required. And sometimes if we have to do, I agree with Devinder that it has to be a staged procedure. And we generally don't do any combined procedure. I have personally done just a couple of implants in these patients, but like I said, fortunately, they don't need, many of them don't need implants because they seem to be doing much better off compared to type 1 keratoprosthesis. But of course, type 1 is the more commonly used one. And we do require to do implants in these patients. So non-valved implants, typically we don't do too many in these patients because the ability of these eyes to hold on with hypotony is very, very difficult. The minute you have hypotony, these eyes behave really, really abnormally. The tube starts coming out, then they start have a pericylindrical leak and things like that. So that becomes very difficult. But yes, smaller size devices and then a staged approach there also, I think would be a very, very useful alternative. Yes, implants like the valved implants do have a problem, but with the hypertensive phase and with the high IOP related to the fibrosis over a period of time. But I think it has to be a judgment that has to be made based on how difficult the eye is and how early do you want the pressure control. So you have an eye where you want the pressures to be down tomorrow, and stage procedure may not be possible in those eyes. I think we have to take into account multiple considerations before one decides on what is required.
Can I make a quick comment?
Yes.
Yeah, with regards to the question regarding the type 2, the osteoodontokeratoprosthesis, I think I have seen a few of them, and no tube is possible. The diode doesn't work in these kind of eyes, and I think the only thing that's possibly useful is the oral Diamox. I don't think anything else is possible other than giving oral medication, and topicals don't work. The tubes are literally impossible to do, and I think you have no option but to just wait and watch and hope that the oral medication works. And the other quick comment is about the micropulse itself and our Indian experience. It's now about 4 years since we've been doing it now, and we have actually accumulated quite a bit of experience in deciding in which kind of eyes it will work and which it doesn't work at all, and which is likely to cause problems. Like it's very clearly mentioned, Dr. Grove has mentioned about the 1/3 it works, 1/3 it doesn't work, and 1/3 it causes problems. And we've learned to identify the ones who are the problem patients in whom we would not venture to do it. It actually works like something like 1 or 2 drugs for the mild to moderate glaucomas, and we don't really expect a fantastic IOP lowering. That's first. Second is that if you have inflamed eyes, you had previous silicon oil, if you had previous uveitis, we would not do it because invariably the inflammation worsens and the hypertony comes in. So these eyes we won't do. And I suppose as a judgment, for example, the case we are discussing about the K-Pro, I would probably do the standard diode rather than the micropulse and do the 180, wait for the watch the response, reassess, and then decide whether you really want additional supplemental laser and so on. And I have just started to do the ACP, which has been recently introduced in India, the 250 Ahmed ClearPath. I think that is probably a good option in these kind of eyes rather than the other options of the micropulse or even the valve device. I think ACP probably holds promise in these kind of eyes.
Yeah, that's the Ahmed ClearPath 250 is my standard tube I now use almost exclusively because I feel like the low profile is nice, and then the smaller size you don't require muscle isolation, so it's really
absolutely
nice.
I think we've been talking to Dr. George. I think he's still there in the panel. I think we've been discussing whether the RD 250 could also come in and really help us in these kind of situations.
You know, it's interesting. I would love to see more data on the micropulse. The way micropulse got approved by the FDA in the US is actually, they said it was the same as diode. They really didn't do a lot of studies, and so they were approved based on the idea that it was the same as diode. And then all the theories that they're saying on the mechanism of how it works with maybe causing a microdialysis or this cold energy or cold laser, it's all theory. They've never proven at all. So I would, I encourage you to continue to publish your results and your settings and your outcomes, because it's remarkable they got approved without really showing any significant evidence that their mechanism of action they're proposing actually works.
So that's been a wonderful webinar, and to have started off our educational initiative of the Eye Foundation with such stalwarts, such wonderfully dedicated and such knowledgeable team of expert panel and speakers, I think it has been an amazing start. thanks to one and all of you for making today happen so beautifully, and it will be there available on YouTube. You could tell your students or your friends to watch it, because I'm sure there's so much learning which has come to all of us in the last 2.5 hours. A most deep-felt thanks to all of you. And thanks, Murli, for being there with me for all throughout the ARC and now too. And thanks to our young Vel Murugan, who had this link running for all of us, and how it all went on without a hitch. Thank you so much. I hope you do go back and enjoy your dinner. Thank you. Thanks.
Good night.
Thank you, Manu.
Thanks, everyone. Amazing job.
Thank you. Thank you.
Thank you.
Thank you. Thank you.